undergraduate work from Barrow University of Science and Technology, and I've been mentored academically that focusing on other extracurricular activities has been hard, but maybe after the PhD, the big question can be asked. Yeah, so in answer to Professor Kaye's question, yeah. 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 Thank you. So I will be presenting a cross-sectional study that was done at Mba Regional Referral Hospital titled Prevalence, Severity, and Factors Associated with Thrombocytopenia among women in the third trimester attending the antenatal care clinic of Mba Regional Referral Hospital. My co-authors were Dr. Munjanyi Godfrey, Abesiga Leonard, Dr. Kayondo Musa, Dr. Ngonzi Joseph, and Dr. Paul Kajiebala. Next slide. Okay. So thrombocytopenia refers to platelet counts less than 150,000 per microliter, and is the second most common hematological disorder after anemia in pregnancy, affecting 7 to 10% of the pregnant women. And prevalence, globally, we have a prevalence of 8.4%, while a study done close to us in Ethiopia had a prevalence of 8.8%. Now, we know for a fact that majority of the thrombocytopenia cases occur in third trimester, and this is majorly because of two reasons. One is because of hemodilution that occurs at its peak at the end of the second trimester and part of the third trimester, and then because of placental sequestration, placental aggregation, and then destruction. Now, there are some factors that have been studied associated with the thrombocytopenia, and among them, we have intrauterine fetal death, malaria, anemia, and some drugs like non-steroidal anti-inflammatory drugs. So our objective was to determine the prevalence, severity, and the factors associated with thrombocytopenia among women in the third trimester that were attending the antenatal care clinic of Mba Regional Referral Hospital. So how did we do our procedure? So we had women coming in for antenatal care, and these women were assessed for eligibility. Now, because part of our objective was to find out in third trimester, we excluded any woman who was not sure of her last normal menstrual period and who did not have a first trimester ultrasound scan. And we included those women that were above 28 weeks of gestation. We obtained informed consent, we administered a questionnaire, and then obtained a sample for complete blood count so that we could assess the platelets. And then we had those that had thrombocytopenia and those women that did not have thrombocytopenia. For those who had thrombocytopenia, we linked them to the highest risk obstetrics unit on Mba Regional Referral Hospital. Now, for our objective one, for the prevalence, this was calculated as the proportion of pregnant women with thrombocytopenia in the third trimester and expressed as a percentage. And for the severity, this was categorized as mild or moderate thrombocytopenia. And for factors associated, we assessed 3 factors: obstetric factors, social demographic factors, and then medical factors. And for these variables that had a p-value less than 0.2 to invariate, all that were considered biologically plausible were taken to the multivariable logistic regression model. And in the multivariable logistic regression model, factors that had a p-value less than 0.05 were considered significant. So for the social demographic characteristics of the participants, the mean age was 27 years. Majority of these stayed in urban areas. They were Banyankole by tribe and had attained a secondary level of education. And for the medical and obstetric characteristics of the participants, majority were HIV negative. They had hemoglobin concentration of greater or equal to 11 grams per deciliter, and majority were in early preterm. They were between 28 to 33 weeks of gestation. And in results, the prevalence of thrombocytopenia in the third trimester at Mba Regional Referral Hospital was 13%. Of the 440 participants, 57 had thrombocytopenia. And for the severity of thrombocytopenia, we had 51 women, 51 of the 57, which made an 89.5% proportion having mild thrombocytopenia. The remaining 10.5% had moderate thrombocytopenia. We did not record any woman with severe thrombocytopenia. In factors associated, one factor became significant at the multivariable logistic regression model, and this was gestational age at or greater than 37 weeks of thrombocytopenia. So in conclusion, the prevalence of thrombocytopenia among women attending the antenatal care clinic in the third trimester is high, and gestational age at or greater than 37 weeks is associated with thrombocytopenia. And as our recommendation, we think a prospective cohort study to assess the impact of this thrombocytopenia among women delivering at Mba Regional Referral Hospital should be put into consideration. So we acknowledge the department, we acknowledge our supervisors, lecturers of Mba University of Science and Technology, our study participants, the audience, and the research team. These are our references. Thank you so much.
Thank you very much, Dr. Pasco, and all of you have been listening to him. We are going to have our second presenter, who on the program you see is Dr. Lugobe, but somebody else is going to present the topic on hypertensive disorders of pregnancy among women admitted at referral level hospitals in Uganda. Welcome. He will briefly introduce himself and then start on the presentation.
Good morning. I'm Onesimus Abyamukama. I'm an obstetrician gynecologist at Mba Regional Referral Hospital, and I'll be presenting this work on behalf of the team that conducted the study on hypertensive disorders of pregnancy among women admitted at referral level hospitals in Uganda. And those are some of the co-authors that participated in this work. Next, please. Oh, sorry. So, eclampsia affects about 2 to 10% of all pregnancies, and the World Health Organization has estimated the incidence and the burden in the developing countries to be 7 times more compared to those in the developing countries compared to those that are already in the developed countries. And preeclampsia itself is a risk factor for cardiovascular diseases later in life. And this study therefore determined the magnitude of hypertensive disorders of pregnancy and associated factors among women that were delivering at referral level hospitals in Uganda. We conducted a cross-sectional record review of patient charts, and this was done at 10 regional referral hospitals and 4 large private non-for-profit hospitals in Uganda from May to July 2021. Data extraction included the blood pressure during admission, the social demographic characteristics, obstetric characteristics, and then the medical comorbidities. And participants that had a chart diagnosis of hypertensive disorder of pregnancy, all those that had an elevated blood pressure were considered to have a hypertensive disorder of pregnancy. And we did marked variable regression to determine the factors that were associated. So in the results, we had a total of 5,791 sampled births, And of these, 67.5% had no blood pressure. Sorry, that's a mistake. They had no blood pressure recorded at admission, and that's a very big number because only 33% had a blood pressure recorded at admission in the regional referral hospitals. We calculated the magnitude of hypertensive disorders at 16.2% of all the births that we had. And when we categorized them as written in the charts, about 63.4 of the hypertensive disorders were not classified. But those that had been classified, 21.1% were preeclampsia cases. And the gestational hypertension was 5.4%, and 2.1% were cases of eclampsia. The other participant characteristics, majority of our cases that had hypertensive disorders were aged less than 35, were marked gravid, had not been referred, were at term and had a singleton gestation and had no history of diabetes. When we did multivariable logistic regression, someone having a primary education and below was about 1.6 times associated with a hypertensive disorder in pregnancy. And being referred was about 2.4 times associated with a hypertensive disorder in pregnancy. And preterm delivery of about had about 1.9 times being associated with a hypertensive disorder of pregnancy. And when we looked at the birth outcomes, we had a higher proportion of women with hypertensive disorders having stillbirths at 4.8%, compared to 2.1% that had no hypertensive disorder of those that we sampled. And adverse maternal outcomes were at 4.9% amongst the women that had hypertensive disorders, compared to 1.9% amongst those that had no hypertensive disorders. So in conclusion, hypertensive disorders of pregnancy are common among women delivering in Uganda, and therefore strategies to increase the level of education, screening for these women in our antenatal clinics, care for preterm deliveries and women who have been referred are needed to improve care for these women for better birth outcomes. And we acknowledge all the participating regional referral hospitals. Thank you so much.
Forward and bring your presentation because we are going to miss it. We are going to have the next presenter, who is Dr. Kenneth Mugabe, using lactate testing to improve maternal sepsis identification, a multi-country test accuracy study on lactate in maternal sepsis. Thank you.
Yes, good morning. Yeah, my job today is just to stimulate you to think about maternal sepsis. As you realize that most of the work and most of the people running around are running around for things like hemorrhage and preeclampsia, because they are the biggest causes of maternal deaths in our country and globally. But we are saying that as you're running around to prevent maternal hemorrhage and preeclampsia, also think about maternal sepsis. So I'm presenting a protocol on using lactate testing to improve maternal sepsis identification. And this is a multi-country test accuracy study where we use lactate in maternal sepsis. So while we are carrying out this study, those are the people we are going to collaborate with. That is University of Liverpool, LCTC, and then Mbale Regional Referral Hospital where I work, Usitema University where I teach, and our sponsor, which is the Medical Research Council in the UK. Lactate, for those of us who don't know lactate, it's a biomarker. And this biomarker usually, it's a function of tissue perfusion. When you have tissue injury as a result of tissue hypoperfusion, you will have this biomarker lactate shooting up in our bodies. So we think that it's a useful test in terms of identifying maternal sepsis. Then the other thing I want to comment on is what's the definition of maternal sepsis? You realize that most of the data that we have in our country on pregnancy-related sepsis is tagged to surgical site infections. But as you may realize, from the sepsis 3 definition, and the surviving sepsis campaign of 2017, WHO already defined maternal sepsis as a condition where you have organ dysfunction as a result of our body's reaction to, or the body's reaction to an infection that has gotten into the body of a pregnant mother, or that one who has recently delivered, the postpartum, or a mother who has just had an abortion in the first 42 days. So maternal sepsis is not only surgical site infection, but it includes other it can result as a result of other infections in a pregnant mother, which can include urinary tract infections, pneumonias, infections in the kidney like pyelonephritis, in the brain like meningitis. As long as it causes organ dysfunction, then it becomes maternal sepsis. So we have a new definition for maternal sepsis. From that definition, you realize that maternal sepsis is a very big burden globally, but in Uganda and Sub-Saharan Africa, we're not able to. Okay. Yeah, so from that definition of maternal sepsis, you realize that the burden of maternal sepsis in Sub-Saharan Africa and Uganda per se is unknown, because most of the data we have they actually just record figures for puerperal sepsis or surgical site infection. But from the MPDSR data, we find that death due to pregnancy-related sepsis is as 10.5%, which is quite high. And like I said, if we are to reduce maternal mortality by 60%, then on top of hemorrhage and hypertensive diseases, we have to add maternal sepsis if we are to reduce maternal mortality by 60%. So you add the 34% of hemorrhage, then you add the 15% of hypertensive diseases, then the 10.5%. So if we are to tackle this issue of maternal mortality, we need to tackle the 3 major causes of maternal death in our country. So when these pregnant women, or those who have just had, who have just delivered, or those who have just had an abortion, get infections, and these infections are not treated, these women get maternal sepsis, like I've described. And if this maternal sepsis is not detected early, it can lead to death of these mothers. So when these mothers get sepsis,
WHO recommends that we use what is called a care bundle to manage these mothers. And in maternal sepsis, the care bundle that we use is called FAST M sepsis care bundle, which stands for fluids, antibiotics, S is for source identification and control, transfer, and then monitoring. And this care bundle should begin within the first hour of making a diagnosis for maternal sepsis. Now, it's very important to use this bundle when we are managing maternal sepsis because it has been found to be effective and acceptable in low and middle income countries. And in countries like Malawi and Pakistan, they have observed that it has led to improvement of indicators like completing vital signs recording and also initiation of antibiotics when managing these mothers within the first hour of suspecting maternal sepsis. So it's very important to use this first M sepsis care bundle in our setting. However, there's still considerable uncertainty around the fact that what's the optimal, what can trigger us to begin using this first M care bundle. If you make a diagnosis for maternal sepsis, what can make you start to use the first M bundle? Is it the temperature of the mother? Is it the CRP? Is it the platelet counts? So we're trying to find out what triggers us to start initiating the first M care bundle. So what we are thinking is, could blood lactate help us do this? Where we are thinking of blood lactate is that most of the guidelines by WHO and other important guidelines internationally have identified blood lactate as a key part in sepsis management and risk stratification, whereby when we have a raised lactate level, blood lactate level of more than 2 millimoles per liter, then we use it as a triage tool to prompt initiation of urgent treatment and patient care, monitoring the care of the patient. And if you have lactate levels that are more than 4 millimoles per liter, then these are the patients where you have to escalate, or you send them for intensive care and monitoring. But these guidelines that are using these cutoffs for lactate are usually in the developed countries, and they're in the non-pregnant adult population. So we want to find out, or we are thinking that there's a need for a high quality evidence-based diagnostic accuracy study to test whether this lactate is useful in our pregnant population. Why we are thinking so is that these tests may perform different in these pregnant women other than in the usual adult population and in the low resource settings. Two is that why it may perform different is that in pregnancy, we know that the physiology of these mothers is very different from those ones that are not pregnant. And the way their bodies respond to infection is also different. Also, the types of infections that get these pregnant mothers are different from those that affect the non-pregnant population. There are also issues of lab, in resource-limited setting. We are thinking, how will this test perform in our setting where we have issues of, reagents in the lab? The population of the mothers we care for are people who are malnourished, anemic, and they are chronically sick. We are asking ourselves, could this test perform differently in our population other than in the population of the developed countries? So what we are going to do is that we are going to carry out a prospective, multi-site, phase 3 test accuracy study, where we are going to study pregnant mothers in Uganda, in Pakistan, and also in Malawi. And this one will help us to increase our, once we get our results, it will be easy for us to generalize our findings, given that it will be an outside study. So in this study, we will aim at investigating if lactate measurement has added benefit over the conventional maternal vital signs assessment in the diagnosis of maternal sepsis. And also whether it can help us identify women at risk of severe morbidity and mortality. So we want to have a lot of, a lot of things to, a lot of interventions. What we'll have to do is to just draw 2 blood samples. One on day 0, when we consent the patient and they are willing to participate, and then 24 hours later, we draw another blood sample. So we'll just draw these two samples, and we'll draw these samples as part of the other routine investigations that we do in the management of patients with maternal sepsis. And the results of the lactate testing will not be shared with the research team. So we shall blind the research team such that we can be able to find out whether this test can make a diagnosis for maternal sepsis. It should not bias the people who are managing these patients based on lactate to manage the patients on the ward. So that's why we shall blind them, and they'll based on other things apart from the lactate levels. Yeah, so that one is the schematic diagram to show how we shall be doing. On day 0, we will screen the mothers, consent them, and then on top of the routine screening and measuring vital signs, we will take off a sample for lactate. And then on day 1, we'll also take off a sample for lactate, but we'll continue with the usual examination of the mother, clinical features, and the usual treatments that we usually do these days as we're managing these patients with sepsis. But we'll also look out for those ones who are near misses. And of course, WHO has a criteria for a diagnosis of near misses as far as maternal sepsis is concerned. Good. So finally, when we get this, we'll also we also compare and see whether when we use the SOFA score. The SOFA score is a score which helps us to determine whether someone has organ failure or not. And it has a number of parameters which are usually laboratory based. So we want also to see if adding some parameters like platelet counts and creatinine levels in the SOFA score is feasible to use in our setting. We want to validate and see if we add those other parameters in terms of diagnosis of organ failure does improve the way we make a diagnosis of organ failure in maternal sepsis or not. Thank you. I'll end there.
Why don't I start with my neighbor here? You said BP was not taken on very large number of cases, but you have no recommendation or conclusion on that. I think from a quality improvement aspect, that is a very big gap. Dr. Kenneth Mugabe, you said you'll blindfold the healthcare providers to whose benefit? As an ethist, I find that challenging. Why? A patient there needs care. For you are blinding yourself so that the results may help improve the patient's outcome. But for you to think that validity of the study is so important that you have to blind the care providers, the ethics of that, I think you need to have a comment. And the advice is probably you could use multivariable prediction models, of which lactate is just one of the parameters. And remember to use receiver operating characteristic curves for your diagnostic test. Otherwise, the way you presented, I'll ask you many questions before I agree that you are doing the right thing. But let's get comments, questions, comments.
Thank you very much. Very nice presentations. I've got a question for Onesmus and a question for Kenneth. So for Onesmus, why do you think that low levels of education would increase the risk of thrombocytopenia? Is that a real finding? And I wonder, did you look at whether the percentage of missing values for blood pressure was the same according to levels of education? I would hypothesize that maybe women with higher levels of education are more likely to have their blood pressure recorded. And therefore, overall, you may have a lower prevalence of hypertension, whereas maybe in women with low levels of education, they only take the blood pressure for the ones who look really quite unwell. And so that might explain your finding. Otherwise, I'm puzzled as to why low level of education would increase would increase hypertension. And then a question for Kenneth. In your study, what is your gold standard against which you're comparing lactate for the diagnostic accuracy study? There's normally a reference. What is your reference standard against which you're comparing? Thank you.
Do we have any other questions, comments to the presenters?
I think I have a comment for the thrombocytopenia presenter. When he was making a conclusion, a recommendation, he was saying that we should do a cohort study. But you already have results. As far as the quality improvement is concerned, from Mbarara Regional Referral Hospital, with a thrombocytopenia of 13% at term in the 3rd trimester, what do you recommend for women who come in labor? Because I would expect that at least they should do a CBC and identify those people who are likely to bleed after delivery. And that is very important for Mbarara. If you have a thrombocytopenia of 13%.
1 in every 10.
Oh, even 10.
Kenneth, just wanted to ask you, what's your rationale of looking for lactate in sepsis? And 2, you want to use the lactate to determine the severity of the sepsis, or just because you kept on saying testing for sepsis, testing for sepsis? Thank you.
In other words, is it a diagnostic model or prognostic model? Lactate, is it predictive or prognostic? So I think if there are no other questions, let's get some of, no questions or comments to, no, he got.
Thank you so much. I think I have 2 comments and questions. Professor Kaya, I agree with you. We should have been specific. We had just put the recommendation broadly as screening for hypertensive disorders. But we should have been specific, and I totally agree with you. I also want to acknowledge that most of these that didn't have blood pressures taken at admission, and the challenges come with availability of the blood pressure cuffs in our hospitals. And you agree with me, in the hospitals that you work, especially if you work in a regional referral hospitals, you rarely have a functional blood pressure cuff at admission. And you'll find maybe a patient gets 1 or 2 blood pressure readings for all the time they're in the hospital. So it's an issue of logistics. And I think we should advocate for these items to be available in our antenatal clinics, in our admission areas. About the low levels of education, we don't have an exact explanation. But one of the things is that that we thought about as a team is that probably these women are not taking enough foods that have the antioxidants, and that's one of the rare explanations that we thought about that could have led to that risk. Of course, it was just an association that we identified, and more studies would really need to be done to identify the causative effect. Yeah, thank you.
Okay, so in response to the concern, now maybe I will go back to the results. When we did the study, among the factors we looked for, we discovered these were routine, these were women walking into the antenatal care clinic with seemingly no complication whatsoever, which made some of the factors not come out in terms of numbers. For instance, I will go to malaria. Malaria, we had only 2 women who did not even have the thrombocytopenia. We had 4 women with splenomegaly, two of whom had thrombocytopenia. We didn't have anybody with multiple pregnancy. So at the end of the day, we are grappling with the situation where we are thinking, could this be gestational thrombocytopenia at the end of the day? Now, when it comes to what has been studied about gestational thrombocytopenia, is that it should ideally have no impact on delivery. But then again, we have all delivered that one woman who delivers normally, then keeps bleeding, your uterus is contracted, you don't have any tears, and you don't think you have left any placental tissue in there. So we're wondering, could we actually go ahead, study these women, follow them up to delivery, and see if this type of thrombocytopenia that we think could be gestation is actually gestational, and will it have an impact on the delivery of our women at Mba Regional Referral Hospital? That's why we thought the recommendation, yes, for testing, maybe at time or doing platelet count would be feasible. But then again, these 57 women who had thrombocytopenia, what about them? Will they deliver normally or not? Thank you so much.
Yeah. Thank you for these questions. First, I will answer the question on the reference standard. In the guidelines, WHO guidelines for the management of sepsis in the adult population, non-pregnant population, they usually use the sequential organ failure assessment score, whereby if you have a SOFA score of 2 or more, then that person qualifies to have organ failure in sepsis. So in our study, we will use the SOFA score of 2 or more as our reference standard. Then, you know, lactate testing is not validated for predicting maternal sepsis in the pregnant population in our setting. So our study, we're trying to find out whether, first of all, it can predict sepsis in the immediate term, where because we are taking the blood lactate samples at 2 time points, that is at day 0 and after 24 hours. So we're trying to find out whether it can predict sepsis in the immediate term, that is at day 0, and also in the short term, which is 24 hours later. So we're trying to test whether it can predict maternal sepsis. That's one. But also we want to find out whether it can be a prognostic marker for maternal sepsis. That's why we are trying to relate it to the near misses and that kind of thing. So we are investigating and trying to find out whether it's both predictive and prognostic at the same time. Thank you.
Okay, that's why I think multivariable prediction models will be very important for you if you want, because so far it's for prognosis, not prediction of illness, but of course it's affected by pregnancy changes. So I want to end this session here, and I want to thank the presenters and all of you who are listening it. Thank you very much. I would like to call upon Dr. Musa Kayondo, who's going to chair the next session. If there's somebody from UMU, Uganda Matters University in Zambia Hospital, if there is one, I've carried a book for them on endocrinology. So they have to deliver it if there is somebody.
Thank you, Professor Kai. I'm going to stand in for Dr. Baragaine Justus for session number 7, which is about newborn health. And you know that's what gives us our work. Without us going to give life, then we'd have no work. In this session, we have 4 presentations. We have from Beatrice Laniero. Please come forward. Beatrice, not around. Levan. And we're going to cancel this session. Doreen. Conference chair, Dr. Kazu, you need to guide me on what to do. Conference chair. Conference chair, Dr. Kaziwe, please. Need to guide me on what to do. I have no presenter. You need to guide me on what the next steps because we have no one presenting in this session. Maybe the CIPRA team, if it's around. Yes. So conference chair, what do you?
Let's CIPRA present.
Then after, because there's.
After that, we shall go by the program.
Fine. Fine. CIPRA, please come forward. CIPRA, one of our partners. Now we'll go for some very good time. They're going to talk to us about pain management. I'll not do so much of their introduction because this is a very well-known company, not only in East Africa, but everywhere. So the presenter will introduce herself, then go forward with the presentation for about 10 minutes. Thank you. About 20 minutes.
Good morning, everyone. My name is Coletta, and I am here to present on pain for CIPRA. So yesterday, Dr. Kaziwe did take you through pain and pain management, but what is important for me today is to take you through, again, very briefly, on the 4-step WHO ladder. And because this is key to the products that I am going to present to you. So WHO did review the 3-step ladder that it had before to a 4-step ladder, right? So why did they do that? Because it is difficult to manage pain, right? It is difficult to categorize pain. And they did give guidance that we can use analgesics, we can use NSAIDs, we can use corticosteroids, and for treatment for all kinds of pain. Now, depending on the type of pain, depending on the type and severity of the pain, there are several adjuvants such as local anesthetics, CTAs, CNRIs that we can use. Now, this is where it's critical for us. WHO also said that combinations of analgesics and opioids may usher in a paradigm shift in the treatment of acute moderate pain in low middle income countries. That point is very important. All right, so I introduced myself. My name is Coletta Nzisa. I'm a brand manager for OTC portfolio, and pain is included in that portfolio at CIPRA. So when do you consider dispensing dispersible paracetamol? When do you consider that? So we have a product called Cipladon. This is one. Or maybe I can move closer to the, okay. Okay, it's not, okay. Right. So the active ingredient in Cipladon is actually paracetamol. It comes in 2 strengths, that is the 500 milligram and the 1 gram. It is classified as a mild analgesic and antipyretic. It is an over-the-counter medication, non-prescription, and it comes in 2 sizes. The 500 milligram has 16 tablets, and it is sweetened with aspartame, while the 1,000 milligram has 8 tablets. So what kinds of pain does Cipladon manage?
Have you ever experienced a throbbing headache that disrupts your task at hand? Do you have fever? Does pain such as toothache or backache disrupt your duties today? Cipladon effervescent tablets have a special formulation containing paracetamol that provides strong, fast-acting relief from pain. Cipladon effervescent paracetamol fizzles out your fever and pain 2 times faster than ordinary paracetamol. On average, normal paracetamol takes 45 minutes to take effect. Cipladon goes into the system immediately and is disseminated through the body, relieving fever and pain. Cipladon works 2 times faster than regular paracetamol tablet. For faster relief of fever and pain, try Cipladon. The fizz works to relieve pain faster. Have you ever experienced a throbbing headache that disrupts your task at hand? Do you have fever? Does pain such as toothache or backache disrupt your duties today? Cipladon effervescent tablets have a special formulation containing paracetamol that provides strong, fast-acting relief from pain. Cipladon effervescent paracetamol fizzles out your fever and pain 2 times faster than ordinary paracetamol. On average, normal paracetamol takes 45 minutes to take effect. Cipladon goes into the system immediately and is disseminated through the body, relieving fever and pain. Cipladon works 2 times faster than regular paracetamol tablet. For faster relief of fever and pain, try Cipladon. The fizz works to relieve pain faster.
So what are the indications for Cipladon? It is used for the treatment of the most painful and febrile conditions, e.g. fever, headaches, toothaches, sore throat pain, period pain, rheumatic and muscle pain, backache, earache, relieving the aches and pains associated with cold and flu. We've been able to see how the tablet works. Now, a study was conducted between effervescent tablets and normal paracetamol tablets. So after 15 minutes, when we look at Tmax, 50% of the patients who had taken Cipladon had achieved Tmax in comparison to 15% of patients who had taken ordinary paracetamol. After 30 minutes, 80% of the patients who had taken Cipladon had attained Tmax in comparison to 40% of patients who had taken ordinary paracetamol. Again, the same study looked at the serum concentration. After 15 minutes, 85% of patients who had taken Cipladon had achieved, had a higher serum concentration in comparison to 10% of patients who had taken ordinary paracetamol. So now, what are we trying to say? Cipladon effervescent tablets work twice as fast in comparison to ordinary paracetamol. This slide talks about an effective analgesic serum concentration, which is between 70 to 230 micromole per liter, right? So in the same study, it was established that 55% of patients who had taken ordinary paracetamol after 30 minutes still had pain, were still experiencing pain because the paracetamol in the blood had not attained 70 micromole per liter. So they were still breathing in pain in comparison to 95% of patients who had taken Cipladon effervescent tablet. So as medics, as doctors, we want our patients to get rid of pain as fast as possible. So Cipladon 500. I want to talk about Cipladon 500. So we are saying that we have children who are too old for syrups, or they are transitioning, yet they are too young to take tablets, right? So what can we give them? We are saying they get difficulty in swallowing whole tablets. We are also saying that if we were to give them suspension, the parent will have to go home with 2 to 3 bottles of suspension. We are also saying that the same group of children, they have already developed taste and therefore reject unpalatable medicine, right? We are also saying that the cost of 2 bottles in comparison to Cipladon 500 for the parent, again, it's economical. Parents again have to endure with waste of leftover suspension medication, because once you open suspension medication, you have to use it within a particular time frame. So Cipladon 500 milligram for children between 8 years to 12 years, it is actually the right drug to give for mild pain for this category of patient, because it is easily dissolved in water, so it eases the consumption. So the children who spit out medication do not have to spit out with Cipladon because they drink the solution. Again, the children remain hydrated. We are also saying that Cipladon 500 works twice as fast as ordinary paracetamol. There is per unit dosing, because you only drop 1 tablet in glass of water. It is cost effective, and then there is no wastage. And we are saying Cipladon 500 is sweetened with aspartame. So again, children will not fight their parents when they're being given this medication. So for dosage for children, we are saying they're supposed to be given 1 tablet up to 4 times daily. And for adults who also want to use the Cipladon 500, we'll give them 2 tablets to be dissolved in water up to 4 times in a day. They're not supposed to exceed 8 tablets. For Cipladon 1000, it's for adults, right? It's for adults. And we're saying we'll dissolve 1 tablet in water up to 4 times in a day. Remember, this is 1 gram, so it's only 1 tablet up to 4 times daily as required.
Cipladon fizzles out fever and pain fast. Cipladon is easy to use with 3 Cipladone fizzles out fever and pain fast. Cipladone is easy to use with 3 simple steps. Fill up a glass with 200 milliliters of warm water, approximately half a glass. Drop in 1 effervescent tablet of Cipladone. Cipladone fizzles out fever and pain fast. Cipladone is easy to use with 3 simple
We are playing a
steps.
second video
Fill up a
on how
glass
to
with
use
200
Cipladone.
milliliters of warm water, approximately half a glass. Drop in 1 effervescent tablet of Cipladone, 1000 milligrams. The tablet will start fizzling and the water will turn cloudy as the medicine dissolves. Allow the Cipladone tablet to completely dissolve and fizzling to stop and drink the solution. Cipladone fizzles out the pain fast.
Cipladone fizzles out pain fast. Now, I want to talk to you about a new product in Uganda, manufactured in Uganda for Africa. So you do encounter patients who come in pain, but they are unable to describe the kind of pain they are going through. You know, a patient will come in and tell you, you know, they will indicate the pain probably by holding their shoulder or holding their stomach or holding their head. Now, did you know that 3 to 4 out of every 10 patients who receive pain medication never receive adequate pain relief? And this is a study that was conducted by WHO, and hence the reason why they reviewed the ladder into a 4-step ladder. So the good news is that with Cipladone and Cipladone Plus in Uganda, it's easy to identify the WHO recommended pain relief medications for mild and moderate pain. So we can clearly differentiate and we can see where Cipladone comes in mild pain, while Cipladone Plus is for moderate pain. And we are saying moderate pain is pain that may interfere with your regular activities. Cipladone Plus for when it's that kind of pain, right? That is what you're saying, because many times our patients are not able to describe the intensity of the pain. So we are saying Cipladone is for that kind of pain. Cipladone Plus is a powerful analgesic and contains an opioid that is WHO recommended to moderate pain. It has paracetamol, 450 milligrams. It has an antihistaminic doxylamine, 5 milligrams. It has mild stimulant caffeine, 30 milligrams, and also an opioid codeine, 10 milligrams. That is the combination. It's a very powerful combination for fast relief of moderate pain. So the indications for Cipladone Plus, we are saying we'll use it in moderate pain, for tension headaches and migraine, for menstrual pain, dysmenorrhea, for neuralgia, and we are also saying for post-operative pain, you can use Cipladone Plus. As you can see, I am very proud and I'm telling you this product is actually manufactured here in Uganda for Africa. Yesterday, we were able to give you samples so that you can be able to go and try it out with your patient. So the indications, I have mentioned the indications. So the dosage directions and use for adults and children 12 years and above, 1 to 2 tablets every day for up to 8 tablets per day. And we should not use continuously for longer than 10 days. Thank you.
Thank you, Cipra, for the great presentation. You can take a seat as we wait and see if there are any questions for you. Before, let's see, has anyone come in during this presentation who is in session 7. Do we have Beatrice? Have you arrived? Laniero? Not yet here. Doreen. So since there is no one who has come in during the presentation and Livan is not here too, so maybe if there is any question for CIPRA, please, about this pain management and the pain medicine. Any question? Fine. So if there is no question, really now, this is the most brief session we have ever had in the history of our AOGU conference.
Thank you very much, Dr. Musa Kayondo, for agreeing to chair this session. We are going to have a slight change in program because I think you saw men in uniform coming in here. We expect the Prime Minister to come in at any time. Suggested something like midday and said things to do with maternal newborn health, she must come. So we have to wait for her. But as we wait for her, we want to see that we create some time so that we are not caught off guard at the time when she comes. So we are going to have some change of program and have the panel discussion, which is supposed to be at 11:20 to now. The panel discussion on the community of practice for sexual and reproductive health. So I would like to call upon the president, Dr. Musana, to come forward because he's going to moderate this session. I would also like to call upon Dr. Kayondo, Simon Peter, and Dr. Pebalo, if he's around. We are expecting one of our dear colleagues, though we are not as learned as him, the lawyer. I don't know whether he is around. Oh, we are most grateful that Council Sam has managed to put in time and come for this meeting. We are very grateful. Dr. Kayondo, Dr. Pebalo. So we are going to have a panel discussion on what a community of practice for sexual and reproductive health and rights is. But before we do that, please, Dr. and Council Sam, please come forward. We are going to have a very brief presentation on that idea, community of practice. Not a very old idea when it comes to sexual and reproductive health, though it has been there before in many other disciplines. And like I said yesterday, for those who are in the AGM, when we went to the meeting in Kigali for the Center for International Health, Reproductive Health Training, it was recommended that we need to establish a community of practice for sexual and reproductive health in the East Central and South African region, and that it should be the Ops and Grind societies to take the lead in creating this community of practice for sexual and reproductive health and rights. So I'm going to give a brief presentation, and then this panel is going to discuss what this community of practice is and how their plans are to ensure that they implement the community of practice, or to ensure that AOGU becomes the leader in strengthening, in harnessing, in fostering, and nurturing the community of practice for sexual and reproductive health, especially in the area of family planning and post-abortion care. Sam? So a community of practice is nothing other than a group of people who share a common concern or who share a set of problems. Now, you know, in the region, we have a lot of sexual and reproductive health problems, which I'm not going to narrate to you, but I will highlight two main issues which are connected. That is the high burden of abortion morbidity and mortality, and the high burden of high fertility, which are connected because usually it is some of the pregnancies that are unplanned that eventually end up as induced abortion and end up as induced abortions or intended abortions, which is the currently accepted term. And then you get abortion complications and mortality. Next slide, please. So a community of practice is a group of people who share concern, problems, or an interest in a topic and who come together to fulfill both individual and group goals. So the community of practice focus on sharing best practices and creating new knowledge to advance a domain or professional practice. And interaction is on an ongoing basis and as an important part of this. So many of you remember our mission as AOGU, maybe the vision first, being leaders in quality reproductive health, and to advance, our mission is to advance excellence in reproductive health in the area of training, service delivery, advocacy, research, and collaborations. Next slide. So a community of practice are formed by people who engage in a process of collective learning in a shared endeavor. They may be engineers on similar problems, a network of surgeons, professionals helping each other cope. So all these. Okay. So there are three dimensions. So there are three dimensions in a community of practice. That is joint enterprises, what this is about, mutual engagement, the interaction that lead to the shared meaning, and the shared repertoire of resources such as techniques, tools, experiences, process, or practice. So that the three features are that there is a shared domain of interest, a community that pursues the shared interest, and practice or shared resources. And that is what I'm trying to say, that in a community of sexual and reproductive health, there is a community of people who have similar interests in ensuring update quality standards in a certain domain. And so a community of practice are formed by people who engage in a process of collective learning in a shared domain. And it's not merely a club of friends or a network of connection between people, but there is an identity defined by that shared interests. So what is the community? In pursuing their interests in the domain, members engage in joint activities. They have shared discussions, they help each other and share information and build relationships that enable them to learn from each other. Maybe as a background to this community of practice, which are talking about, FIGO, which is advancing this idea, sponsored 10 OBS and GYN societies internationally to implement advocacy for abortion care, safe abortion care. And in that area, from lessons learned, in Africa, there are about 4 countries, that Mozambique, Zambia, Kenya, Uganda, and the 5th one joined later, which is Rwanda, and Ethiopia, which had been supported earlier. So it's from lessons learned that it was realized that there is need to increase activities of the associations as a community of practice. And the characteristics of the community of practice, when it comes to practice, I'm sorry the font is very small there, but I just mean that these are people who are interested and work together on different activities in the different areas, which this team here is going to talk about. So what do community of practice do? They solve problems, they think about common issues, they explore ideas and act as sounding boards for each other. They may create tools, standards, designs, manuals, or other documents. Over time, they develop a unique perspective of their topic, as well as a body of common knowledge, practices, and approaches. So this is what I'm trying to say, that the three areas overlap: the domain, that is focus, guides learning, provides meaning and value and common identity. Then the community, the people and their characteristics who interact in practice, and then the practice, mutual engagement of community members in the activity of the domain. So many of you know about this, the elements of post-abortion care, which include emergency management of complications, which is referred to as treatment there, counseling, family planning, contraceptive services. So these were the initial three elements of post-abortion care, but later on, two were added. That is, the need to link post-abortion care to other sexual and reproductive health services, such as cancer screening, gender-based violence screening, STI screening and management. So there need to have linkage to other services. And then there is need for community and service provider partnerships. So now the elements are 5, and a community of practice has a lot to do with ensuring that those elements are realized. The picture you see there shows you what a community of practice could do, that they have a common purpose, trust among members, shared knowledge, shared practice, collective intelligence, implicitly held knowledge, and so on. I'm going to the last slide, that eventually the community of practice creates an enabling environment for sexual and reproductive health to be realized. And you can see the various areas like ensuring health literacy, supporting laws and practices. We are very grateful to have a lawyer among us. So anything related to the law in sexual and reproductive health, I'm not able to answer some of those questions, but he definitely will be able to do so. Support, information, education, empowerment, access to justice, health financing. So you find that all these are what is required in creating an enabling environment for sexual and reproductive health. So we are going to have a discussion where the teams here, moderated by the president, will discuss how AOGU can try to increase the services provided as a community of practice in the area of training, service delivery, advocacy, collaborations, and mutual learning or research, which is some people think should be applied research, which does not include primary research, but learning from each other's activities. Thank you very much. I'd like to call upon the president to take over. Thank you.
Learning does not stop. However, sometimes we look for certain answers and we find them in presentations. So I'd like to talk about the community of practice. AOGU, in our mission, talks about excellence in clinical practice. It speaks about excellence in research, excellence in collaborations, excellence in advocacy, and excellence in training. So our community of practice is around those 5 things. Now, because of the nature of the environment we are living in, many of us have key technical skills or knowledge or competences. Like the Eurogains can form their own community of practice with other training and other things. However, I would like to narrow it down to abortion and contraception and family planning, because that's an area we have really tried to think about as AOGU, and also in line with sexual and reproductive health rights. AOGU, with the permission from the council, after deliberation, published a statement, a position statement on abortion. People have been calling AOGU the abortion organization, but that's something we have to discuss because it is there and it's not going to go away. And the statement, as you read there, outlines our position as an association on abortion in Uganda. Some of the council members are here. It took us close to 3-4 years to reach a position. And of course, the background is that women are dying from abortion and its complications. Both the legally allowed and also the ones not allowed within the law. But we shall talk about that. Now, abortion, I think, continues to, even I think as we're estimating deaths from abortion, we don't normally put clear numbers because reporting is not very good. So our position is on that statement that AOGU believes that whatever services we offer around abortion should be within the non-legal and regulatory framework of Uganda and our standards as professionals. So if you move lower on that statement, there is a legal and policy framework on abortion in Uganda. And of course, people keep asking, and sometimes people are denied services because of the lack of clarity around the law. The legal policy framework, first of all, the law is supreme, which is that one, Article 22. And that's why we have a lawyer on this side to talk about the legal aspects in case we professionals fail to deal with them. So of course, the law says no one has a right to terminate the life of an unborn child, except as authorized by the law. Then for the penal code, which implements that law, the penal code is also law, if I can ask the lawyer, right? The penal code is also law. So the Constitution is the supreme, then this is also law. So the penal code on issues of abortion, section 142 speaks about procuring. And thereby, this talks about the woman herself. If the woman being with child has an intention to procure her own miscarriage, and by doing that, she tries to administer to herself any poison or noxious thing, or uses any force of any kind, or any other means, or permits usage of such things to her, commits a felony and is liable for imprisonment. So the first part of the law says that if a woman has an intention to, and tries to administer or allows the administration of such things that may lead to a miscarriage or an abortion, commits a crime. I hope I'm using the right words, legal counsel. Yes, let's move to the next one. So the woman is punished by the law for an abortion. Then section 143, supplying drugs to procure abortion. Any person who unlawfully supplies or procures for any person anything, knowing that it is intended to be unlawfully used to procure a miscarriage, you also commit a felony or a crime, and you can be imprisoned. So if you knowingly supply treatment or drugs or whatever method, then of course the last section there speaks about those of us who do what we do in clinics, surgical operations. So a person is not criminally responsible for performing in good faith and with reasonable care and skill a surgical operation upon any person for his or her own benefit, or upon an unborn child for the preservation of a mother's life. So most of us, I think, are using this one to offer things like preeclampsia and others. So if the performance of the operation is reasonable, having regard to the patient at the time and to all circumstances of the case. So those are the aspects of the law, and the position of the ministry. The last position we had was in the policy of 2006, National Policy Guidelines and Service Standards for SRH, that in some instances, a woman or a girl should be assisted to terminate a pregnancy, and one of them was rape, incest, defilement, severe maternal illness threatening the life of a woman, cardiac disease, renal disease, preeclampsia, fetal abnormalities not compatible with life, e.g. molar pregnancy and the rest, or HIV positive women requesting for termination. So that is as far as we have on the law and the policy. The council will talk about that later as we as we think about these issues. Then, of course, what is the position of AOGU? AOGU's position, as discussed by the council meeting that time, is our priority is reducing the number of women dying from or suffering from poor quality of life, from complications due to unsafe abortion. And AOGU's position is we shall do this through advocacy that promote equal access to abortion care for all Ugandan women within the existing professional, because we remain professionals, legal and regulatory framework. We must train our members and other healthcare providers in evidence-based medical and surgical termination of pregnancy within the existing frameworks. Then, of course, as AOGU, we support scaling up of all interventions and activities that prevent unplanned and unwanted pregnancy. And the key intervention here is family planning and contraception. We can move on. So as AOGU, we do not encourage or support intended termination of pregnancy outside existing professional, legal, regulatory framework. But we support the right of each woman to access clean, safe, and timely post-abortion care in line with our policies as a country. We don't support regulations or provider attitudes that lead to or fuel discrimination or delay or lead to denial of post-abortion care services to women regardless of their characteristics, whether adolescents, whether they're in their late 40s, whether they're menopausal. We don't support any regulations that deny women care. And we support respectful care, people accessing post-abortion services. But AOGU does not also support harassment of healthcare workers that provide abortion-related services which are within the legal framework. Many of our health workers have been stigmatized, sometimes put in jail for offering abortion-related services, including post-abortion care. So we don't support that. So that is the statement of the association. It comes from a background of advocacy, reality, but also rights, because women have a right to access services. And it is in line with that that I will then move on to the community of practice. And this community of practice is around integration of family planning and abortion-related care. You can't dissect the one from the other. So I will start with Dr. Kaye, since he's the ideologue and also some of the people understand these things. Why a community of practice for sexual and reproductive health rights? That is number one. Number two, how has AOGU, and during your tenure as the AOGU Executive Director, how have you aided the process of a community of practice around this issue?
Thank you very much, Mr. President. Why a community of practice? I think I don't want to reiterate the vision and mission, but when you are going to pursue excellence in the areas of research, collaboration, service delivery, there are activities that must be seen that you are doing on the past realization of your mission. So it's important that AOGU takes lead to ensure that, especially because AOGU does not provide services, but at least it can regulate service standards. AOGU contributed to the development of guidelines in maternal and newborn health, where an important section on post-abortion care was included. So the way they manage emergencies like preeclampsia or sepsis, which Dr. Mugabe was talking about, is the same way you manage some of the emergencies for abortion care. For instance, the 4 complications of shock, sepsis, bleeding, and intra-abdominal injury. Once somebody is trained in post-abortion care, they can also use the same approaches to managing other cases of sepsis. So in that way, AOGU can contribute to improvement in service delivery for patients. They can also develop service standards. What are the minimum requirements for service delivery. I think other people will talk about some of these areas, but there is an important gap in the information available on abortion because hospital records don't have adequate data. Sometimes cases are not reported, even if they are managed in health facilities. I'll leave that for some of my colleagues to elaborate, but I'll tell you about the big gap in nationally available data. The Demographic and Health Survey, it has only one question on abortion data, and the question goes, for you in the last 5 years, have you had an abortion? Asking a woman of reproductive age, have you had a miscarriage, a stillbirth, or a neonatal death? I don't know how many people can, if they answer no, what does it mean? It means has not had any of those. But how about yes? What does it mean? And that is the only question in the DHS, in the national available data. So there are gaps in data. The information at health facilities is not adequate. So as a community of practice, as obstetricians and gynecologists, we need to advocate for the availability of this data because this data is necessary not only to inform best practices, but also to inform policy and development of guidelines. It also can inform the scope of practice. It can also inform requirements for human resource availability. Before I leave, as I know time has gone, I wish to acknowledge one of us, Dr. Susan at Haile, who has done a lot of research on the mid-trimester abortion, why we didn't have any data. She has done a lot, wrote a lot of papers, and provided a lot of evidence on how to manage mid-trimester abortion. We can't fail to acknowledge her. And so there are a lot of data gaps, which as obstetricians, we can identify and see how we implement. Thank you.
Thank you, Dr. Kaye. Administratively, as an association, how have you tried to build that community of practice on sexual reproductive health and rights?
One way we have tried to do that is to partly to in the development of the statement on abortion. We have also had training of members, but also the other cadres, the midwives who are part of our associate members, but also key partners in providing services. For instance, just this year alone, we have trained over 160 healthcare providers in the central region and about 30 in Western Uganda on post-abortion care. But we also train them on that aspect of how do you manage patients who might need an abortion within the policy, because the curricula don't have any information on it. But within the legal framework, they are required to provide some services. So we also give them information about how to safely provide those services. So in the area of training, we have been very active, but also ongoing support for trainees. We have established a WhatsApp forum for trainees, all the people we train, so that we can have a forum for having CPD, Zoom meetings every 2 weeks, and having regular discussion to share experiences, updates, challenges. Even today, there was a staff who submitted information about some of the challenges she's facing in the field. So as AOGU, we feel that we have a responsibility to be the leaders. Actually, it's not just more than a responsibility, it's an assignment to be the leaders so that we improve training and mentorship. And I'm sure my colleagues will talk about other areas where we have played a key role. Thank you.
Yes. I will continue with the issues I understand best. Dr. Kayondo, you have led and coordinated one of the biggest projects in AOGU for the last 3 years, the advocacy for the prevention of due to unsafe abortion. And I'm aware that you are leading in and participating in one of the biggest coalitions around that aspect of care. So as a participant, but also as a leader in that community of practice, who are your community of practice and how have you engaged or supported them to ensure that they actually build knowledge, they grow, and that the issues surrounding abortion are brought to the core to the public.
Okay, thank you, Chair. For me, it's been an opportunity to actually understand the depth of the concerns around the issue of abortion, controversial as it may be. Whereas we know that regardless of what we feel about it, it still ranks among the top 5 causes of maternal mortality. So it is not something we can sweep under the carpet. In Uganda, we have definitely adopted a model that we can work with within the restrictive policy and legal framework, and that is the abortion harm reduction model, which has been proven, first tested in Uruguay, to show that you can actually reduce deaths and disabilities from unsafe abortion while continuing to be within the country's legal framework. And that is the reason I think why AOGU has not pushed for legal reforms around abortion, because we feel that there are a lot of things we can solve before we even look at the law to reduce on the number of deaths and women who suffer disabilities. So the coalition you've talked about first, the local coalition in Uganda, is we work with other partners who may understand things we don't understand. Like the colleague on my right here understands the law and policy better than we, the doctors. But we also know that there are CSOs in the area of women's rights, youth groups, and so on. So work together to put our heads together to find solutions. Abortion harm reduction is a concept that we have been trying to speak to all our members, especially AOGU members, but also all health workers to implement, and we believe it is something that can make a difference in the lives of women. So the idea is, if a woman approaches you with an unwanted or an unplanned pregnancy, what should be your response? Your response should not be to turn them away. Your response should be to give them a listening ear, listen to their concerns, explore their issues and why they may want to terminate that pregnancy, counsel them about safe and unsafe methods of pregnancy termination, and speak to them about options for an unplanned pregnancy. None of this is outside the law of the land, and it can make a difference. If you tell a woman what is likely to kill her, she'll probably not use that. And where you feel you're probably convinced to, you may offer appropriate referral. Now, if the termination is within the law, many of us know that most of the time we go ahead and offer it. But if it is not within the law, that is left to your judgment. So the community of practice takes us outside the Ugandan context to the regional context, because this is EXA region. And we know that there are countries in this region that have made tremendous success in terms of reducing deaths from unsafe abortion. And we can talk about countries like Ethiopia. Very, very big difference. Rwanda is seeming to follow in that line. So when we speak to them, when we convene with them, we learn from what they have used, and we borrow the positive messages from the way they, but we also offer them information on what has seemed to make a difference here. As I end, I would say that a concept like values clarification and transformation of attitudes is something that has seemed to work effectively in Uganda. Impact research has been done around it, and there's a very big difference it can make in regard to change in the way that healthcare providers deal with women who approach them with an unplanned pregnancy. I know that Dr. Pebalo will probably speak to having tested that mode in terms of training in a training institution. So I'll leave that to him. Thank you.
So thank you, Dr. Kayondo. Do you believe there is a need to make a community of practice locally outside the wider EXA on issues of sexual reproductive health rights and rights?
Yes, definitely. Like Professor said earlier, community of practice is a group of people who share common interest, who share common values, who have a similar goal, and they bring together knowledge, expertise to make a difference. And they are committed to taking it forward no matter how long it takes. So whereas we are looking at the regional level, but yes, it is a good thing that as professionals and as obstetricians, by the way, and gynecologists, people really expect us to offer lead in sexual reproductive health rather than following. So if we can also make a community of practice locally, even within AOGU, I think it can make a very big difference in our efforts towards improving SRHR, both in training and service delivery.
Dr. Pebalo, welcome. I'd like you to share some of your experiences in the areas of training as regards abortion and family planning, and how these are integrated in your day-to-day work or in your vision as a practitioner, but also as a teacher.
Yeah, thank you. I want to start with how I was trained first. I think I had how I was trained. In my internship, I was actually trained in a missionary hospital, and talking about family planning, talking about abortion, even providing family planning services was a bit difficult thing. So we actually got out as medical officers. Basically, we were not able to do even inserting an implant. So I thought this is an opportunity for us if we need to have community of practice, so that we start building this from the beginning. We have people who are still young that would be able to actually join the community of practice so that it is sustainable. And that's actually an important element that probably we're not looking at it then. But I think this is something that we already, as Gulu University, as Gulu Hospital, and then Lacho Hospital, we are trying to integrate this. What we're able to do is that to make sure that people have good attitude, people are committed, people have a common mandate. We needed to actually start this earlier. And how do we start it earlier? One thing that we're able to do is that we're able to do what is called the hidden curriculum. How do you handle a case of abortion? How do you handle a case of family planning? Someone who came with side effects of family planning, how do you stick to the patient before your juniors, before the students, before other colleagues? And that's very important to build a community of interest and community of practice. The other thing that we're able to do is that we did what they call the arm reduction model. And that's something that we already actually introduced into our training. The first thing that we do is that when we are doing a kind of abortion training, one of the things that we integrate that is harm reduction model, so that healthcare providers, lecturers, and then other tutors that are there in these teaching hospitals are able to appreciate that there are avenues where this provision of abortion care is important. And the other thing that we're able to do is value clarification. We know stigma is something that is there, and we cannot run away from stigma. And many healthcare providers back up, or they are not able to help our patients provide services because of attitude, or they feel that they are going to be stigmatized. And we're able to actually clarify some values, make sure that they understand there are certain circumstances under which someone can actually come for with an intended pregnancy, and how we can be able to handle them is really very key. And that, I think, that actually help us a lot to make sure that we build a kind of people who respect our patients. Patients come to you for many reasons. Patients become pregnant for many reasons. And there are certain things that as a healthcare providers, you can be able to provide. As Dr. Kayonda has put it clearly, in the harm reduction model, of course, you know, there are areas that as a healthcare providers, you're not supposed to actually touch. That is the area where it is restricted. But before abortion occurs, there are things that you're able to do. Maybe you can actually direct this person to talk to someone, maybe a religious leader. Maybe you can actually people to talk to someone, this this patient, to change their attitudes, to make sure that they're able to keep the pregnancy until delivery and probably give the baby for adoption. Also, after abortion was already occurred, we are all aware that a majority of the cases of post-abortion care that are admitted in our hospitals are actually due to induced abortion. These things are started from somewhere and end up being incomplete abortion in your words. So our idea is that when you come to us, you should not act like a state operatives. You should not act like a police or like my brother here, like a lawyer. You start asking someone what happened, why did you induce? Your work is to offer the post-abortion care. Whatever the case is, what happened behind that, your work is to actually be responsible as a healthcare providers. And that's what we are trying to do as a training institution, to instill to our students to actually join the force, to have a better attitude in managing post-abortion care and family planning. Thank you.
Thank you, Dr. Pebalo. I would like to take this back now to Dr. Kayonda before I come to my colleague, the council. Values clarification. What is values clarification or value clarification? Because the members of the House, and what do you do when you're talking about value clarification? Are these attitudes, are these beliefs, are you changing my values? Because me, I cast out demons, so should I change my values?
Okay, thank you, Chair. So the idea is clarification of values, not change of values. If it was change of values, it would be called that. The issue is the exercise assists you examine yourself, your beliefs, your choices, yes, your professional values, your ingrown cultures and norms. And let me go to health providers who still turn away post-abortion care patients because they have agreed to the fact that they actually terminated this pregnancy with the intention. I don't know if in the room we know that this is still happening. So when I agree, the history taking is up to how this incomplete abortion started. And at that point, the patient is sent away because I don't agree with how it started. Whereas offering post-abortion care is a mandate, it is still not universal. Of course, for many other reasons, other than attitudes, there are also system challenges with skills and the necessary supplies. But the fact that you think that this was done and it was wrong, and therefore the patient should suffer for it, you are a candidate for values clarification. So it's not about changing. It assists you self-examine and then understand why you choose what you chose, and then decide if what you chose is the right thing, or you think you need to take on an alternative, because the exercise brings you together in a room with people with multiple beliefs and multiple different values. And then whatever you choose, you prize it, and then you take action. Those are the steps of values clarification. So it's not really change, but it is very important for change in attitudes, because positive attitudes assist service delivery, or they assist patient care. Okay, let me give a simple example from Eastern Uganda. So thousands of healthcare providers went through VCAT sessions, and then a year later, impact research was actually done. And you had these healthcare providers confess to the fact that they actually used to turn women away on just a mere mention of, I have an unwanted pregnancy. And they were saying, now I give them audience, now I give them confidentiality, now I give them privacy, and we discuss the options for this pregnancy. And it has made a difference. I never used to offer post-abortion care. I would give it to my colleagues, and now I am directly involved. They have set up post-abortion care corners, and they are active. Many have agreed to taking up and learning more skills in performing MVA, and they are assisting women. So it makes a difference. There is evidence that VCAT makes a difference, but the aim is not to change your values, probably to change your attitude. Thank you.
So if for us who believe that when you are bought, there's a demon. So if that's my belief anyway, but I have to change, my values will not change, but I have to understand that I have to offer the service to the patient, regardless of my values. So I think value clarification, some of us were value clarified. Is that the right terminology? So I understand better that I have to offer the service and be compassionate, kind, and other things, regardless of what the woman has told me, and regardless of whether I think whether it is doing right or wrong. Yeah. So let us go to our partner in this community of practice on SRH and rights. Council.
Yes, Doctor.
How does the legal aspects help in our community of practice in this regard? Given that now you're dealing with an audience of mainly obstetricians, midwives, and how does this help in us delivering services regarding abortion care and or family planning?
All right, thank you very much. Pushing straight to that part of the discussion, the position of the law has been very ably stated in the previous presentation by you, Your Excellency. And indeed, I confirm that that is the law as it is today. Now, the same law, if you go on to have a deeper understanding of it, provides for what is not permissible. We saw Article 22.2, non-termination of the life of an unborn child, except as may be allowed by law. Goes on to provide also for under the penal code, like he ably stated, those circumstances where it is illegal and punishable. In section 224, like was already ably put, we see that the same law trying to beef up the Constitution, where it says except as may be permissible under the law, it provides for a few of those, that thin restriction to which termination of pregnancy, or rather known as abortion, may be done or provided, executed. Now, the starting point is getting to know all of this information, and gladly AOGU is willing to offer the same information. The effect of this to us in the medical world
to medical practitioners is that when presented with a patient or someone who has issues related to abortion, then you have firstly the information as it is today, and it is incumbent upon you to make a decision as to what course of action to take in that regard. Now, we know that one who is informed is best placed to make one of the greatest decisions from personal conviction. So, like my colleagues, the professional doctors have already put it, when you have information, the harm reduction model was brought in, you could choose what course of action to take. Dr. Simon spoke about the counseling and giving as much information as possible. That is the second element I would like us to know, that if you have this information, you're able to disseminate or convey to the patient that is before you. Now, that is another effect of this.
Let me give some quick fire.
Yes.
Is abortion illegal in Uganda?
Abortion in Uganda is restricted.
Restricted.
Restricted, yes.
So does that section of the Constitution, the right to life, does it make it illegal or restricted? Because it says no one has the right to terminate the life of an unborn child, except as may be authorized by the law. So is that restriction or is it completely illegal? Because we know the law is supreme, medicine is not supreme, policy is not the law. Under what circumstances can we offer, as a community of practice, abortion care in Uganda?
Okay, thank you very much.
And what would be your advice to AOGU and its partners in putting out this information as clearly as possible to members as to when or where abortion and abortion-related services are legal or are within that law? Because first of all, is the law clear on the indications for abortion?
Currently, as it is, we keep, from the legal world, we keep emphasizing the word restricted to a few of those circumstances. When you go deeper into the discussion of the law and the current legal regime, vis-a-vis answering the question also and advice to the general medical world, is that under section 224 of the Penal Code Act, it uses certain keywords.
Some.
Yes.
Some. Yes. Please place that abortion statement on. Abortion statement.
Okay, thank you. The law, Constitution and the Penal Code is silent on particular medical practices, but it uses the terms, let's go to section 224. Below, right there. Section 224 of the Penal Code Act of the laws of Uganda. A person is not criminally responsible for performing in good faith and with reasonable care and skill a surgical operation upon any person for his or her benefit, or upon an unborn child for the preservation of the mother's life, if the performance of the operation is reasonable, having regard to the patient's state at the time and all circumstances of the case. Some of the key terms I would like us to properly understand is the use of the words good faith, reasonable care and skill, and preservation of the mother's life. Yes, ultimately, whatever operation is carried out ought to be one for the preservation of the mother's life. But how does one assess or make the decision as to when they think they should carry out the termination of the pregnancy, the abortion, or when they should not? Now, starting point, one ought to be well trained. And that means they have the reasonable care and skill that they can put into play. Secondly, in good faith, of course, as a medical practitioner, you ought to have
good intention, not ill intention of performing the abortion. Normally, when one is arrested or one is brought before the law as regards an alleged offense of abortion, the starting point, we see a lot of rough play. When we go into a deeper understanding, those who are able to interpret the law, it is when we break down some of these ingredients of the offenses, and normally we realize that actually some medical practitioners have provided post-abortion care, and some people have erroneously interpreted it to mean provision of abortion. So some of those thin circumstances are keenly, if a medical practitioner can ably note that and bring evidence that it was for the preservation of the mother's life, and there was reasonable care and skill that they put into play, and all of this was done in good life. That is the restriction to which the abortion can be conducted.
So for many of us, you know, we have defined health as a complete physical, mental, social, and the other one is what? I think there are four. Emotional. There's physical, mental, social, emotional, well-being. That is the definition of health.
Yes.
So what do we mean in good faith? So if I am emotionally unwell, can I ask for a termination? If I am socially unwell, can I ask for a termination? Would that be good faith? Would it be within the law? Would it be, because these are some of the things we have ratified as a country.
Okay. If one is emotionally unwell, like Dr. Simon ably put it, there is that session under the harm reduction model of counseling and giving as much information as possible. I know as doctors, you're able to assess and ascertain one's complete status and well-being. Now, if a patient presented to a doctor, a medical practitioner, who fits this criteria, and they are emotionally unwell, that may not necessarily pass the test. Why? Because there is a likelihood upon counseling of being well later on and changing their opinion and decision about the termination of the pregnancy, the abortion.
So, because these are issues that are going on in the discussions around the community of practice, that if a woman tells you, I want to commit suicide because I'm pregnant, what happens? If a woman tells you, if I go back home, I will receive as much as I can. So what would be the advice to the association on, as we develop guidelines, as we talk to partners, as we advise our members? Because that question keeps coming up.
Okay. Before I even hit that on the head, we have that you clearly also put the 2006 national policy guidelines that bring out a few of those circumstances where to which termination of pregnancy abortion is restricted. They have the fetal abnormalities, the preeclampsia, etc. Vis-a-vis one's unwellness, a patient's unwellness who is presented to a medical practitioner. Now, by and large, I know that as AOGU, there's keen interest taken in the harm reduction model and a few of those good practices. So the best advice given is also emanating from section 224 of the Penal Code Act. To say one acted with reasonable care and skill, it is not just a one statement. It is looked at in a wholesome manner. That in your skill as a medical practitioner, what would you have done in those circumstances? Would you jump straight to say, okay, you've told me you're unwell, or you intend to carry out the abortion simply because you're worried that you may be beaten at home? What other option may be available in your professional skill as a medical practitioner? Should you counsel them? Should you provide them with as much information as possible to enable them come up with an informed decision as to whether to go on with the abortion or not? Now, the discussion on reasonable care and skill extends as far and wide as that. So the hard and fast rule should be that the initial steps
have the patient in, record as much information as possible of how they came, and what is your opinion as the professional, and what step do you think is reasonable? You can even go on to consult from your colleagues or make referrals. That would help in those circumstances. So what you're saying is that AOGU needs a community of practice just to deal with the question of abortion. Yeah, in a way, but I know Professor, what do you have to say about that?
When you look at the issue of abortion, it's not just a medical problem. The root cause of why people eventually decide to terminate a pregnancy may be social, in the household, in the community, in the workplace. So it's not just a medical problem, it's a social problem, it's an economic problem, it may be a religious problem. So you need to address the total context. And as gynecologists, we need to understand that we are bound by the ethics, yes, but there are other players who may need to address the root cause. So we give them the poke, we highlight working with them so that they can mobilize the community, help educate the community, religious leaders talk about their role of parenting, talking about good behavior, so that we highlight the points for primary prevention. We highlight the point for secondary prevention. We also highlight the activities to address the 5 elements of post-abortion care, which are in the tertiary prevention, so that we work with all the different stakeholders and identify what roles each of these people could do. For instance, the project, we engaged parliamentarians, religious leaders, traditional healers, so that each of these can have a role to play, as long as the ultimate goal is stop women dying from abortion complications. All of us can play a role. And then the good thing about the community of practice is we acknowledge that because people have values, they can have them clarified so that they can balance their professional obligations and their values, to know that they can provide beneficent care, non-maleficent care, ensure justice, and ensure patient autonomy. So telling them about their rights and giving them the benefits, risks, and alternatives empowers their autonomy. And then finally, know that you need to balance the patient's rights and your personal values, to balance your professional values versus your personal values. And that's where value clarification becomes important. You talked about the issue of the health. Some people who look at health beyond the biological factors, the psychological, the spiritual, and sometimes they are more important. For example, pregnancy after incest, psychological factors may be much more important than the physical. And some people want to look at the expanded mode of health, about dignity. Suppose somebody was raped and is pregnant. Isn't that an issue for dignity? People may say, well, it's not an issue. But to some people who are faced by that issue, it may be a very important issue related to their well-being, their dignity as individuals who are raped, are now pregnant and carrying a baby whose partner they never had anything to do with. I think those are situations when people may consider that spiritual well-being, the psychological well-being, those other domains beyond the biological, and then on a personal basis, and that's where Section 224 may come in, the whole circumstances of the case. And it also provides for conscientious objection. If you cannot do for your own values, it is okay. But there are steps which you need to follow, maybe to refer, maybe to advise, maybe to call upon your colleague to handle what you cannot handle. There are guidelines about how you go about it, which makes it easier for people to acknowledge that as you have your values, patients have values, your colleagues have values, and becomes a big problem. Like if you are the president of an association where people have different values, I think it's better to have a pragmatic approach whereby you recognize that your people who follow you have values, much as you may not support what they do because of their values, you acknowledge they have the values different from you. And that's the first step of a community of practice. Acknowledge others may be different from you with their values. If you cannot respect them because of their values, at least acknowledge they are entitled
to their values. And that's the beginning point of a community of practice.
Thank you, Doctor. Just in a minute or so, in brief addition to that, all of these activities and circumstances actually support the right to life in a way. And we also know that from the Constitution, Article 33, clauses 1, 2, and 3 provide for the rights of women, and that they should be accorded full and equal dignity with a person of a man, and the state providing state facilities, amongst others, so that the proper healthcare provision can be made for purposes of the women. So the discussion extends as far as that.
Thank you, Dr. Pepalo and Dr. Kayondo. I know you are actively engaged in training. I know you actively engaged the different training curricula and looked at them and assessed them. What were the things you found as regards abortion care and or family planning? And were these integrated in the curricula? Are they comprehensive or it's deficient?
Thank you, Chair. Yes, we took an opportunity to look at the different curricula for different training institutions. Universities own their curricula, but there are some cross-cutting curricula, like for nurses and midwives. For all the universities that gave us a go-ahead, we looked at the content in the curricula, and also for the nurses and midwives training institutions. I think without mentioning specifics, there is a lot more that needs to be included in those curricula. I think because of the prevailing legal and policy frameworks, institutions and curricula tend to teach less and less and less about abortion care, so that it is left to the learner to find some way during the field practice, by apprenticeship, or to learn about how to do it, which drugs, which doses, where does MVA qualify. I have seen a woman who almost bled out because an MVA was being performed on a 24 weeks pregnancy by someone who says they are skilled, so they are finding their way around the field to know how to do it. And the indication was preeclampsia. It's very interesting. So the curricula have less and less information, less skilling about how to actually terminate a pregnancy, even within the law. When we're working on the essential maternal newborn child health guidelines with the Ministry of Health, again, the hesitancy on giving detail, even detail on how to deal with a missed abortion, the hesitancy in giving that detail in the guidelines, again, came from the law. If you say more, is it acceptable within the law? Institutions have been asking if it is legal to teach about the law on abortion. I think that health providers should be taught on what the law says on abortion. It's a very controversial subject. They should be taught on what it says. But it is something we've been struggling to get institutions to include within their curricula. I think Mbarara University has taken lead on this. Let's give a big hand to Dr. Musa Kayondo. He was very proactive. He said, our residents need to know this. We should just, and they've gotten it into their draft. Guru is moving in the same direction. We are waiting for other institutions to take up the same spirit. Abortion harm reduction has nothing controversial about it. We think it should be in those curricula. Let our learners, let our healthcare providers know how much and what extent they can go to assist a woman who presents with a controversial subject of I will have a pregnancy that I don't want to keep. They should know to what extent they can go, but also issues of skills. So the curricula have gaps at different levels. We appreciate their efforts to address that. and AOGU is continuing to speak to the stakeholders. Thank you.
Thank you, Dr. Kayonda. I think in the interest of time, let us just wrap it up. Professor and the community of practice on SRH. AOGU has a committee, a subcommittee on SRHR, and it's headed by an associate member. Sister Dong, where are you? If she's here. And Sister Sechimpi Sisi, as part of our efforts to bring this to the core. I do believe that I think as we move forward, it's not just on abortion, but also MFM and other issues to come up with their own communities of practice and set standards, and also advocacy points that we should push. I would like to thank the panel. I would like to thank the work that the project has done. I'd like to thank our members in the community. I know the issue of abortion is very contentious, but I think that women should not die from unsafe abortion, whatever the reason. So I would like to, I think, hand over to the chairperson of the conference, Dr. Kaziwe. Please, a hand clap to the members here.
Thank you, my president, Dr. Musana, for taking us through this session. Can we give another round of applause? And the team. Thank you, dear panelists. We are due for break tea, but before that, again, this aspect of supporting each other, there is again a raffle draw for the team that has taken part. I will invite the newly elected president, step forward and help us conduct this exercise for the two lucky winners. Yes, what we do, we pick out all this, close your eyes, you shake a bit there. Thank you. Select out one of them. You have not closed your eyes, sir. Wonderful. And the lucky winner is the first one. Read the number. See your number up there. 033. 033. The lucky winner. Can you step forward? The name is? Quick. Okay, Mubangizi Vincent. Vincent Mubangizi, please step forward for your prize. The next one is 026. 026. Kaketo Hindu. Kaketo Hindu? Is it Hindu or Hindi? Oh. The other one who can receive the gift, the prize on the paper. Mubangizi, I don't know, is going to receive the Dr. Wanyama, one of us. Okay. Dr. Wanyama has come forward, bring the prize. For a moment. Members, let's have 20 minutes break and then urgently return to continue with the program. Thank you.
around $300 to $400 per operation. And we have limited data on predictors and outcomes since this surgery is not readily available. But some scholars have put forward some predictors for surgery, which ranging where the site of the fistula, the degree of scarring, whether the patient has had a previous repair, and the expertise of the surgeon. The objectives were to describe the types and etiology of female genitourinary fistula over our 12-year period, which we have mentioned, and also to determine the successful fistula repair rate at 6 months after surgery, and also to determine what predicts the successful repair at 6 months after surgery. We did this. This was a prospective cohort study. It was multi-centered and different sites. That's Mbarara, Chitovu, Windi Community Hospital, Nakaseke General Hospital, and Nira Regional Referral Hospital. And we recruited all patients who had underwent repair for the fistula by the surgery team, by fistula surgery team of MAST. We classified our fistula at examination and anesthesia into 3. We took an obstetric fistula. This is a fistula which is due to obstructed labor. And these were the fistulas which were located in the lower genital tract. That is the urethrovaginal fistula and vesicovaginal fistula. And then those which were high up in the genital tract, and this following a pelvic surgery, that's a C-section, a cesarean hysterectomy, an obstetric hysterectomy for maybe postpartum hemorrhage or piperosepsis, vaginal or gynecological hysterectomy for fibroid, or a vaginal hysterectomy for prolapse. If a patient got any fistula after that and was high up in the genital tract, that is cervical, vesicouterine, vaginal vault fistula, or a ureteric fistula, we took that as a fistula created by the surgeon, that's iatrogenic. And then the congenital fistula. We followed up our patients for a period of 6 months. That's at discharge, 3 months, and at 6 months after surgery. And then we determined the outcome at 6 months. And our outcome of interest was a successful repair, and the successful repair was any patient who had been done surgery and was continent of urine at that time. An unsuccessful repair was either someone who was still incontinent, and the incontinence could be due to a urethral incontinence, what we call stress urine incontinence, despite closing the fistula, or a failed fistula closure, which was demonstrated by a positive dye test. Then we did log binomial regression to determine predictors for successful repair. So in the results, in the 12 years, we managed to operate on 532 patients with genitourinary fistula. This is only urinary fistulas, not rectovaginal, but only urinary fistulas in the 12 years. And we lost 22 during the follow-up period. And we see that majority of these are patients above 35 years, and they are still married despite having the urinary leakage. They are still with their partners, and they had stayed with the fistula for more than 1 year in majority of the cases. When we looked at the fistula characteristics, most of the fistulas were urethrovaginal in 34.9%, and we're going to have a surgery for the first time. It was a primary surgery. It was not a repeat surgery in majority of the cases. And most of the operations were done through the vaginal route. And as you see, our complication rate was low in about we did have complications about 90% of these patients. When you go to the etiology of fistula in our patients whom we worked on, we see that fistulas due to obstructed labor are still the number one causes in about 66%. But there was also a large number of a significant number of about 33% where the fistula was caused by the surgeon or with the health worker. The outcome, our successful repair rate was 81%, which was quite high, and an unsuccessful repair of 19%, but most of this unsuccessful repair, still the fistula was closed, just that the patient still had urethral incontinence. When we look at this rate over a period of follow-up time, we see that when you were discharging these patients, the successful repair rate was really high, about 88% at discharge. But as you continue following them up, the successful rate goes down. In that at 6 months, it had gone down to 81%. And we see that most of the reduction in the successful rate, that's these patients, despite being discharged continent, some of them became incontinent, and this was mainly after discharge up to 3 months. That's when the reduction occurred most. When we looked at the predictors, we found that marital status, that someone who was separated or divorced had lower odds or had less odds of having a successful fistula repair. Probably this, healing is a process. Not only you need support, psychological, social support. So probably these patients who did not have care providers and also feeding, patients are in our hospitals, they have to feed themselves. So probably this could lead to the low rate odds of having successful repair. And then patients who were grand multipara were more likely to have a successful fistula repair compared to those who were prime paras. This is probably in a grand multipara, you have since most of our operations were done through the vagina, so you have a lot of space, vaginal room probably to approach the fistula as compared to a prime para where the space is limited, more so if the obstruction was really, really very bad. And the urethrovaginal fistula had less odds also of having a successful repair. And then a patient who has had a previous unsuccessful fistula repair was less likely to have a successful repair at this period of time. So we found that our successful repair was 81%, but this was a little bit lower than the World Health Organization recommended of 85, and also what was found in other studies. This is probably because some of these studies use different measures for success, where they included for them success was closure, which was different from us who used only repair. And the urethrovaginal fistula was less likely to have successful repair because we know that a fistula at the urethra will not only have a fistula, but also have disruption of your continence mechanism. So even if you close the fistula, you're unlikely to get someone continent. So in our conclusion, our successful repair is rate, despite it just being less than the recommended World Health Organization rate. And patients with urethrovaginal fistula, those who have had a previous repair and those who are separated, are less likely to have a successful fistula repair. So such patients should be left to the most skilled surgeons to work on them. And we see that we should follow up our patients for longer periods of time in order to determine the final outcome of the surgery we have done, rather than determining the outcome only at discharge. So I want to acknowledge everyone, and I thank you for listening.
Thank you so much, Dr. Kayondo, for this very wonderful presentation. A very long period of follow-up for this fistula patient who are actually very helpless. And I think that's a big work. That's a very big, good work for them. And you've seen that actually up to 33% of the fistula patients were due to iatrogenic cause. And I think because of that, I would like to invite Dr. Onesmus to come and talk about the rising trends of iatrogenic female genital urinary fistula in Uganda, so that it emerged together with the previous presenter. You have 10 minutes to present. Thank you.
Thank you, Chair. I'm Onesmus Vyamukama, and I'm an obstetrician gynecologist at Mbar Regional Referral Hospital. I'm also a fellow of female pelvic floor surgery and urogynecology at Mbara University of Science and Technology. As the IT, okay, thank you. But I want to acknowledge my mentor, Dr. Kayondo Musa, who has just presented. And what I'm going to present is part of the work that has been done during this period, 12-year period. Also want to recognize my most recent teachers, Dr. Spire Chugunda and Dr. Sema Timba. I'm happy to sit on the same panel with you. So I will talk about the rising trends of iatrogenic female genital urinary fistula in Uganda. And next, please. Oh, sorry. Yeah, so 95% of the genital urinary fistula that we see are actually of obstetric origin. And that means you have prolonged, neglected, obstructed labor that causes ischemia and necrosis and later creates a hole between the urinary and the genital tracts. However, we've been seeing an increase in the iatrogenic fistula during our daily practice. And these observed trends are due to improved obstetric care, because obstetricians, midwives are able to recognize the early stages of obstructed labor and do an intervention, but also gaps in medical training. Some of the risks for this iatrogenic fistula could be due to the anatomy, because we know the urinary and the genital tracts are in close proximity, and therefore during pelvic surgeries, it's easy to injure the urinary system. But also the indications for surgery, especially obstructed labor, if you get tears that extend to the vagina, that extend to the cervix, during the repair of the tears, you might end up injuring the urinary system. And previous surgeries, because of the dense adhesions, healing by fibrosis, and separating them sometimes can cause these injuries. A complexity of surgeries where you have excessive bleeding, especially in cases of ruptured uterus, but also massive adhesions, and limited skill and expertise of the surgeon. So our objective was to describe the trends in the etiology of the genitourinary fistula in Uganda. And we did a retrospective review of data of women who underwent surgery for genitourinary fistula at 4 regional repair sites. The Mbara University of Science and Technology Urogyn team conducts camps in Mbarara. In Greater Buganda region, we have 2 sites, Masaka, that's Chitovu, and then Nakaseke General Hospital. And then we have a site in Bwindi, and then in northern Uganda, where we go to Rila. So all these participants had an examination and anesthesia done for them, and a methylene blue test to determine the type, but also locate the fistula
and also determine the number. So we classified the fistula as iatrogenic and obstetric. And the high fistulae, like the ureteric, viscocervical, viscouterine, and the vault fistula following an obstetric or gynecological surgery were classified as iatrogenic. And then the obstetric fistulae, we mainly consider them the mid-vaginal, mainly the mid-viscovaginal, and then the urethrovaginal fistulae. This classification has been used by This classification has been used previously by a number of urogyn surgeons, and it's what we adopted and adapted. So the trends of both obstetric and iatrogenic fistula over the 12 years were described and compared. So the baseline characteristics, almost 96% of our participants had no formal employment, and about 58.5% of them were married, and slightly more than 37% of them were multiparous. When you look at the etiology, the obstetric fistula are still high at 66.4%. But we see the proportion of the iatrogenic fistula very high as well at 32.4%. When you look at the trends over the 12-year period, we could see that initially we had a decline or a reduction in the obstetric fistulae, and that was from 2010 to about 2019. But then from 2010 to 2019, we can see that we have had a steady increase in the iatrogenic fistula with peaks in 2015. Now, from 2019, we've had a sharp rise in both the iatrogenic and obstetric fistula. Much as the obstetric fistula still remain high, but we can see that we have a sharp rise in the iatrogenic fistula. The iatrogenic are the blue ones. When we look at the types of iatrogenic fistula that we had, most of them were viscocervical at 42.0%. But we still have the ureteric fistulae very high at 24.3%. When we looked at the types of surgeries that led to these fistulae, we can see a cesarean section contributed 71% of the iatrogenic fistulae, and most of these were as a result of obstructed labor. But we have other indications like 2 or more previous cesarean section scars contributing slightly more than 18%, and then the other indications. Obstetric hysterectomies also contributed a significant number, 21.3%, and most of these were from ruptured uterus. And gynecological hysterectomies contributed about 7.7%, and most of these were from the benign gynecological conditions. So in conclusion, we are seeing a rising trend of iatrogenic genitourinary fistulae, and most of these follow a cesarean section and obstetric hysterectomies. And this is a worrying sign on the quality of health care that we give, but as well as the training systems that we have in place. And therefore, we recommend that there is need to improve the training in surgical skills for both obstetric and gynecological operations, especially cesarean sections, which is the most common performed obstetric operations. I want to acknowledge Mbarara University of Science and Technology and Mbarara Regional Referral Hospital, as well as Medicine for Humanity, which is an organization in the United States. Thank you so much.
Thank you so much, Dr. Nesmas. Thank you so much. If you have question, you would first note them down. There'll be a time that you'll be able to ask the presenters. Can we have a presentation from Dr. Spire Chigundu? It's about minimal access surgical skills transfer in Uganda. A 2 years experience at Enrope Hospital. Doctor, you're most welcome.
Good afternoon, everyone. I want to thank AOGU for organizing this event. I also want to thank everyone who is here. I want to acknowledge my faculty in training and Henry Hospital for what they have done to get us this far. Today, I've come to share with you our 2-year experience of skills transfer in minimal access at Henry Hospital, Zana. Chigundu Spire is my name, and I'm a guy in minimal access surgeon. I want to start by saying that minimal access has been available for some time, and the uptake in the Western world and is more than 90%. The challenge we have here is that the uptake in Africa, especially the low-to-do countries, is still alarming at less than 10%. And we believe that this is not a good sign. So how do we get there? It has to be training. Of course, we know that minimum access is increasingly being used in high-income countries because of its numerous benefits, which we all know. And in comparison with open surgery, we know that minimum access is associated with reduced infection rates, reduced postoperative pain, short hospital stay, and all these benefits really would attribute much to changing outcomes in low and middle income countries. More because hospital beds are scarce, families must rely on single breadwinners. And I think this is one of the main reasons why we have to take it up. Previous studies have shown that training of minimal access in low resource settings is feasible, but uptake has been slow due to various barriers, including the issue of cost. I looked at some studies done by Professor Galkande and Diombwe in 2017. They reported cases of diagnostic laparoscopies, started way as far back as the 1990s. And with support from several partners, including UCSF, University of Vermont, several hands-on trainings were organized at Mulago Hospital from as early as 2007. Indeed, the first surgeries in Uganda were conducted around this time. Short courses were undertaken in Nairobi, India, Europe, North America, that was on mainly individual basis. In 2019, a number of specialists benefited from training scholarships by State House. And I think this was the major breakthrough of the journey of minimal access. The first curriculum-based minimal access program was started by Dr. Anderbat at Bethany Hospital, where I was also first exposed. And this was taken up by 7 specialists. That was 2019. However, because of obstacles here and there, not many were able to move on to level 4. So following this exposure, of course, some specialists upgraded in India, including myself. In 2020, after getting some skills and getting better, we decided to start a program at Henry Hospital. In this program, we train residents, several specialists in different specialties, different surgical specialties. But we also acknowledge that most med programs in Uganda still lack a well-developed minimum access curriculum, even though varying degrees of exposures, as you saw earlier, have been given. This was the beginning of our journey at Bethany Women's Hospital. And you can see that we were excited to have a bit of hands-on. Unfortunately, this program did not live long, and some of us had to take various avenues of attaining the skill. What is our experience of training at Henry Hospital? The first curriculum was for 3 months. That was a pioneer curriculum. It was a certificate program in 2020. This was later upgraded to a 4-month fellowship curriculum in 2021. We so far trained a total of 65 specialists, and that is in a period of 2 years. 60 of them were Ugandans and 6 from neighboring countries, Kenya, Somalia, Sudan. 45 of the trainees were qualified specialists, while 7 were residents. The average baseline skill level for our training was about 70%. The trainees, they were at 0. 70% of the trainees came in at 0 skills or minimal access. 30% of the trainees were at skill level 1. That means they're able to do simple procedures, or they have been exposed or worked with someone. And 58% of these trainees left at level 2. Level 2 means that the trainees are comfortable to do diagnostic procedures, while 42% were still at level 1. None of them was at level 0. This picture shows you a bit of a dry lab and skills transfer, where our trainees start from the dry lab to perfect their skills of dexterity, depth perception, high-hand coordination, and eventually, with time, we expose them to the patients in different levels of exposure. The outcomes, trainees, we've noted that trainees with prior exposure demonstrated more commitment and high skill levels at the end of the training. Trainees with access to personal endo trainers and trainer kits usually learn faster. And trainees participating in full-time programs, whether they align with us for 1 month, apprenticeship, or 2 weeks, tend to do better than those who do it on a 1 day a week, because we have those provisions. Trainees with access to laparoscopic towers, obviously, at their work environments tend to retain the skills. What are the gains? The program has helped to establish practice in a number of hospitals in Uganda. For example, I can bear testimony that we've trained specialists in the major hospitals in Kampala who have been able to start practice in Mengo, Rubaga, Nsambia, Kawempe, Chivuli, and a number of private hospitals. And we also have trained people up country. In Mbarara, we have trained like 4, and Masaka and other areas. And with this, we've seen an upsurge of uptake, and most of these hospitals are now able to offer minimal access to most of the patients. Of course, with this, you will note that the cost of this valuable service has reduced with time because you have now a bit more surgeons. The only way you can bring down costs is obviously if you have more people offering the service compared to before. We have more suppliers of minimal access equipment to help us with equipment, unlike before when we had to import them from India and Europe. And now we have more public awareness, including insurance companies coming on board because of the pressure. Of course, this has not come without challenges. These are some of the challenges we faced in the last 2 years of training. The size of intake has been capped at around 6. We would have really wanted to have more trainers come on board, but because of cost, it's sometimes a bit difficult. Then even with the little cost we attach to the training, we find that people cannot afford, and the money we get, we use it to sponsor cases. There are commitment challenges and equipment challenges. Of course, I also have to mention the issue of accreditation. What are the recommendations? The program should endeavor to incorporate structured minimal. I'm talking about MED, sorry. We think that MED programs should really primarily be responsible for incorporating minimal access structured training, and this will help to pass on skills primarily to the residents. This is because they have enough patients and more room and perhaps more support. And we also think that the more privileged private hospitals should really take up the practice to improve regulation and quality control. We need more investment in minimum access and at all levels. With this, I want to thank you very much. I have to continue to acknowledge the team I work with, the trainers, including Dr. Sematimba here, and we hope that the gospel will trickle down to everyone so that we reduce the gap of the benefit of minimal access in Africa. Thank you very much.
Thank you so much. Thank you so much. I can assure you, when we think about laparoscopy from Gulu, we just have to refer the patients Kampala. So I think this is also good news for us. The team in Gulu, the team in Lira, should be able to think about coming for exposure so that we take the services closer to our population. I'm happy the team from Barra were able to come for that. I think that's very good. Thank you so much, Dr. Chigundu. This time I want to invite Dr. Sematimba Kato Stephen to come and present a complete pelvic peritoneectomy, laparoscopic and surgical management of endometriosis. You're welcome, Doctor.
Good afternoon, everyone. I'm Dr. Sematimba Stephen, laparoscopic surgeon, GYN from Henry Hospital. I want to acknowledge the presence of my teachers from MED and undergrad, and my boss, Dr. Chigundu Spire, who also doubles as the head laparoscopic surgeon at Henry Hospital. So I want to present our surgical management of endometriosis. And I'm talking about laparoscopic management of endometriosis by complete peritoneectomy. Peritoneectomy means denuding the peritoneum, or stripping the peritoneum. Okay, so that will be our outline. To remind ourselves, endometriosis is a disease characterized by a presence of endometrium-like epithelium and stroma outside the endometrium, and usually and is usually associated with chronic inflammation. Not the word inflammation, because most cases we forget that endometriosis is associated with inflammation. So the exact prevalence is unknown. However, with studies estimate about 2% in the general population and up to 50% in females of reproductive age with infertility problems. I need to let you know that most of the females we treat with chronic pelvic pain and infertility are patients of endometriosis, but most cases they are treated as PID. So while not all women with endometriosis are symptomatic, endometriosis is sometimes associated with, most cases associated with chronic pelvic pain and infertility. And this is the hallmark of this disease. It doesn't only affect the women, but also their families. So we note that also we have had challenges previously with staging all the forms of endometriosis, and there was no universal way of staging endometriosis until a classification called the #New Enzian classification, which describes the location, the size, the regions, and the involvement of other genital tract organs plus adjacent organs. So I'll encourage everyone to look at this. When they go back, look at the #Enzian classification. This is what we use at Enrob Hospital. It's used by both the sonographers, the laparoscopic surgeons, and everyone who attends laparoscopy, or everyone who's involved in the management of endometriosis. It describes briefly the different lesions, including peritoneal lesions, ovarian lesions, tubal lesions, and also has compartments A, B, C, and D plus F, which describes other organs. So please endeavor to look at it. If there are any postgraduate students, please take it up. This is what we use universally as laparoscopic surgeons to classify our endometriosis. So what are some of the indications of peritonectomy? We said peritonectomy because we said endometriosis is involved, has a lot of inflammation. So it benefits the laparoscopic surgeon and the patient more so to denude the peritoneum. So we do peritonectomy in all those patients with obvious endometriotic nodules, pelvic sidewall adhesions, pseudopoaching. All these things can only be easily seen on laparoscopy, and patients who benefit from this. Patients who have pelvic pain, who have patients who we think fertility is important to them, and also it has helped us to decrease recurrence of this disease because it's a recurrent problem. Because of the continuous inflammation of the disease, the first surgeon is usually the most important surgeon, is the most vital surgeon for managing endometriosis. Most cases we have gotten patients who have been opened up like 3 times, and then most cases we find a lot of trouble dissecting and separating tissues meticulously because our people don't take note of the fact that endometriosis is very common, and they just term it as a frozen abdomen. Most of the frozen abdomens we meet are as a result of endometriosis. So in our preoperative care, all our laparoscopic surgeons have to examine the patients, do a speculum examination, which will help us to take especially the deep infiltrating lesions in the posterior vaginal vault. Then we do bimanual examinations, and this will help us to examine the adnexia, the cervix, and also we do digital rectal examination to rule out any infiltrating nodules. We also do, the gynecologist is responsible for this, that's the transvaginal scan. So the laparoscopic surgeons have also been trained to do transvaginal scans to look out for these nodules, and which are usually responsible for pain. We usually go through steps, which may be a bit out of scope for this presentation, but it's very important for all our patients to have transvaginal scans because it's the most important modality for diagnosis of endometriosis. Then before surgery, all our patients get enema. Depending on the surgeon, some people give 12 hours before surgery and 2 hours before surgery, depending on your preference as a surgeon. Enema helps us to empty the rectum because we know most of the endometriosis, which obliterates the posterior cul-de-sac, will have involvement of the rectum. So important to work on the rectum when it's empty. So peritonectomy, what is the technique? It's in a summary. I have a short video. In summary, it's important to consider surgical optimization. And if hysterectomy is planned, we think it's important. You first do the peritonectomy as the uterus provides an excellent counter traction during the procedure. So we use a uterine manipulator or temporary uteropexy. We hang the uterus up on the anterior abdominal wall, or oropexy, which assists in the visualization of the cul-de-sac and ovarian fossa. And the key to safe dissection, sidewall dissection, is identification of the ureter and the vasculature. This requires the surgeon to have optimal knowledge in pelvic sidewall anatomy and generally female anatomy. So peritonectomy is accomplished by judicious use of electrosurgery and adequate traction on the tissue, combined with gentle pushing movements. So when delineating the path of the ureter, it's very important because it's the first hallmark we use. The ureter is our friend when you're doing peritonectomy because it gives us direction, and we need to make sure it's preserved as is. So when delineating the path of the ureter, both instruments used apply gentle traction, and then we sweep parallel the tissues parallel to the ureter to identify the vasculature ureter plus the superficial retroperitoneal structures, including the hypogastric plexus. So the cul-de-sac dissection is approached laterally to enter the rectovaginal space. We go through these simple steps as a basket for all our patients because we think it's safer and easy dissection that way. So the rectum is identified visually by its characteristic longitudinal fibers. And I need to tell you, as we are dissecting, we take note of the superficial pelvic spaces, including the pararectal space and paravaginal spaces. Pararectal space is very important to create because when you create it, it helps to push the rectum further away from your point of dissection. So note that endometriosis may also distort the anatomy of the rectum. So sometimes it's pulled much higher. So you have to be cognizant. And that means we need to insert a rectal probe to delineate its anatomy, so that when you're dissecting along it, you don't enter into all the layers of the rectum. So in conclusion, our laparoscopic peritonectomy can be used to assist with the diagnosis and management of pelvic pain and infertility in patients with endometriosis. However, it can be safely performed with adequate knowledge of anatomy and basic skills in laparoscopy. Thank you very much. Can we share just a short? I have a short video showing a patient who came in with just 2 minutes, 1 minute, 1 minute. Patient who came in with a frozen abdomen. We had to do peritonectomy. I just want to show them how it begins and how it ends. So this is, I think this was our last patient last week. So this is the patient who comes in with infertility, chronic pelvic. Most of our patients present like that: infertility, chronic pelvic pain. So most cases, if you're doing open surgery, you will stop there and close. So we started with in most cases, we start with mobilizing this, the sigmoid. We start on the left, mobilizing the sigmoid. We use electrosurgery judiciously and with caution, of course. Most of the patients have benefited from this because we have had some successes of patients coming back when you're pregnant and preventing. Can you go to the end, please, of the video? Show how it ends. Show it ends. At the end, we expect to identify its structure and then identify the ureter, the apogastric plexus, also did appendectomy, and all other structures, most of them including the superficial retroperitoneal structures. And we placate the ovaries on anterior abdominal wall for 48 to 72 hours. This enables the peritoneum to regrow, so the patients don't get fresh adhesions just within a short time. Thank you very much.
Thank you so much. Thank you so much, Dr. Stephen. You have a question, you would actually note it down, and then we'll be able to get that later. There was one person who missed presenting in the previous session, and that is Sister Doreen Mazakwe. Doreen, about the prevalence and factors associated with early initiation of breastfeeding among mothers delivering by cesarean section in Mengo and Rubaga Hospital. You have 10 minutes to present. Thank you. You're most welcome.
Good afternoon, everybody. Pleased to be here. I present apologies for not making it at the time that I was supposed to. I'm sure you accept them. I'm privileged to present this postgraduate research, which was done in from 2019 to 2020. With concluding with a recent graduation. So that's the title of the research project that was done. And I would like to start off by asking us a question. How many of you, put up your hand, if you are confident that you would starve a baby who is less than an hour old? Put up your hand. Like intentionally, you would, during surgery, because these are C-section moms, when that baby is born, how many of you would willingly want to starve a newborn? Nobody, eh? I assume it's nobody. And yet, our research has found that there are a number of things that are not going right. So as a way of introduction, early initiation of breastfeeding is defined as putting a newborn baby on their mother's breast within the first hour, or for that baby to feed within the first hour at the breast. And globally, only 44% of mothers are initiating breastfeeding within 1 hour. The question is, what is the fuss about that hour? So with mothers who deliver vaginally, the baby's skin is covered with, vaginal fluids, and the baby is put on the mother's skin immediately, and they're usually allowed to breastfeed, which allows the baby to access colostrum, which is rich in protective factors and is directly related to reduction in neonatal mortality, according to research. In Uganda, the prevalence of early initiation of breastfeeding is only 66%, and yet over 70% of mothers deliver under skilled care and with a skilled attendant, but also in a health facility where there is skilled support. So the question is, why is early initiation of breastfeeding at such a low rate in our country and globally. Sorry. So one also wonders, you know, what is the problem we are looking at here? The issue is that today's C-section deliveries on the butcher block. I've had people talking about it, and I would also, you know, add my weight on that butcher block. It has been shown to be a persistent barrier to early initiation of breastfeeding. And with rising rates of C-sections from 2006 at 3%, to 2016, in 10 years, it doubled to 6%. And it has been shown that there is a dose-response relationship of delayed initiation of breastfeeding as the sections rise. So we looked at, collecting this data from mothers who are delivering in private settings, specifically private not-for-profit. You know the challenges of collecting data in a private facility. So we looked at a private not-for-profit facility where C-section rates are higher than in public hospitals. Kalisa and his colleagues conducted this research on delayed initiation of breastfeeding, but among a whole group of mothers, those who are delivering vaginally and those who are delivering by C-section. So our study specifically looked at those who are C-section mothers because they are usually eliminated, and so sometimes the data collected is not enough. So we also looked at this area because there is paucity of data in this particular area. What is the problem if a mother does not breastfeed early? There will be issues with unnecessary supplementation, pre-lecture feeding, which already have proven problems which occur to these infants, causing infections and dangerous things like neck. So our objectives were to look at what the prevalence is among these mothers and what the barriers and promoters are. Okay, I will move on from the literature review. And so we collected our data. Our study was a mixed study, a cross-sectional study, and we collected data from quantitative data from C-section mothers within 24 hours of delivery. And we also collected qualitative data from key informants who were mainly obstetricians and midwives. So here are our results. I will go straight to them because of time. Our results were disheartening, but we were not surprised because we had already seen that trend in other facilities in other countries. The nearest was Kenya, where the prevalence was 25%. In our study, our prevalence was 18%, which according to WHO is classified as poor. And if the national prevalence is 66% in the larger population, 18% is definitely disheartening. The three most important factors associated with early initiation of breastfeeding were rooming in. Rooming in means that a mother and a baby are kept together in the same room constantly, day and night. And so we found that mothers who were able to keep their babies with them were 6 times more likely to initiate breastfeeding early than those who were not able, who were separated from their babies. So, and the simple explanation for that is that mothers who are with their babies in the same room are able to observe hunger cues and ask for their babies, you know, and to also ask for their babies to breastfeed them. The other independent factor was hospitals that had practices that were similar to those under the baby-friendly health facility initiative, if you heard of BFHI. So particularly here, it was Lubaga Hospital, which had policies and practices, even if they were not BFHI designated, they had those some of those policies favored the early initiation of breastfeeding. The third factor was multiparity. So mothers who had more than one baby were likely to initiate breastfeeding early of course, because they are more confident, but also because they are, their self-efficacy is greater than those who are primipary mothers. So there is a prevalence showing that we had more mothers in LH, which is Lubaga Hospital, than Mengo Hospital. And for the reasons I have explained, particularly in one of those hospitals, babies were immediately separated from their mothers the moment they were born. And in the same hospital, there was a general wing where mothers were kept with their babies. So even within the same facility, when the policies don't favor early initiation of breastfeeding, we have such outcomes. However, it's interesting to note that by the time we finished our study, we had more mothers initiating breastfeeding, I think because the health workers were tipped off, which is a good thing though. So, okay, I've explained that. So in the qualitative part, we spoke to midwives and obstetricians, and they gave us a few pointers on what they considered to be barriers to early initiation of breastfeeding. The commonest one was post-surgical pain, because according to Fielder, when mothers are in pain, they will pay attention to their pain and they will not want to breastfeed. And I'm sure there are so many innovations in managing pain right now. Also, side effects of anesthesia. A very interesting one was some mothers were worried that the anesthesia drugs would get into their babies before, if they breastfed before the anesthesia wore out from their lower limbs. So definitely there's a lot of education to provide there. Also lack of education and knowledge on the side of patients, but also on the side of health workers. Unfortunately, health workers were being educated by formula companies, which definitely provides a conflict of interest. Under promoters, the controlled prescription of infant formula was an important promoter, where in one of the hospitals, mothers were not given formula, even if they felt that their breast milk was not enough, simply because they were trying to control access to formula, which we found was an important thing. And as you see, the next point is, assistance by the midwife to breastfeed. This is a very important factor because mothers are depending on the professionals around them. They trust them that they will be able to tell them when they should get their babies to the breast. I will just share the recommendations. Two strengths. I feel that our strength was that we collected data from a true population of C-section mothers only, and not just a general one, but also we were able we were limited rather by recall bias, and the data we collected was through a cross-sectional study, so we might not be able to infer, but also some of this information though can be used in private settings. Our recommendation is one, and I feel this is the strongest recommendation we can make, and especially to a room full of people who can already be advocates for breastfeeding. The baby-friendly hospital initiative has been around for long. I feel that if we upscale and speed up facilities taking up these practices, we will be able to ensure that our breastfeeding rates go up, especially the main outcomes, which is initiation, exclusivity, and duration. Thank you for listening to me.
Thank you so much, Doctor. We may need to change a little bit, but for now, Honorable Prime Minister is around. Very soon she will be joining us in here. But I think as we wait, as they are about to enter, we would actually still continue with Dr. Kayondo's presentation. Dr. Kayondo has two presentations and would actually lovely give him 15 minutes for the two presentations. Dr. Kayondo. Thank you.
I'm back, but I'm just going to I had 2 presentations to make, but I'm combining all of them into one. And I'm going to talk about pelvic organ prolapse, which is part of the pelvic floor disorders. IT. So I'm talking about pelvic organ prolapse in southwestern Uganda, and specifically I'm going to talk about its impact on the quality of life of women and how surgery can improve that quality of life and get the recurrence rate after surgery and the factors which the risk factors for recurrence at Mbarara Regional Referral Hospital. I'm going to use these 2 pictures just to, with the permission from the patients from which they were taken from, to tell what pelvic organ prolapse is all about. And we know it as a descent of any part of the genital tract through the vagina or outside the vagina.
Just a moment. Can you rise up and as we welcome the Honorable Prime Minister of the Republic of Uganda?
Dear delegates, with us is a guest of honor. Let us start this session with the national anthems. That's the East African and the Uganda national anthem. Uganda first, East African. our seats. Our Right Honorable Prime Minister, the AOGU President, both elect and incoming, senior members of the Association of Obstetrics and Gynecology, let me take this opportunity to once again welcome you for this AOGU Scientific Conference. To the Right Honorable Prime Minister, the team in this conference hall is mainly composed of the obstetricians or the health workers that are qualified, or skilled birth attendants that are qualified in the maternity and newborn care services. So, and two, we also have midwives in the house. We have residents, postgraduates that are coming from all the universities in Uganda in this room. So to my speech quickly, which is on page 7 of the AOGU booklet, if you can help me open for the Prime Minister, the program on page 7, we are referring to that to guide the way we are progressing. So quickly on the program, we shall have a abridged version. Sorry, we have paused the panel of discussion, but you can stay where you are. We shall have the speech or address from the chair, organizing committee. We shall have a speech from the AOGU president. We shall have a keynote address from Prof. Peter Waiswa, who will in turn invite you, Right Honorable Prime Minister, to address the gathering. So quickly moving on to my address to the gathered members here. Right Honorable Prime Minister, AOGU members and delegates of the 17th Scientific Conference, thank you for sparing time and honoring the invitation to attend this conference. You deserve a hand clap. It can't be called a scientific conference if we don't have presenters, and these teams presenting are really researchers that are both in public institutions and in the private sector. And they're doing a great job in terms of sharing their results to improve the way we offer services in the institutions where we serve. Honorable Prime Minister and the delegates, allow me to thank the government of Uganda for enhancing the salaries of the scientists and health workers. This has motivated us to really invest a lot of effort in terms of improving quality of care and working towards reducing morbidity and mortality in all disciplines of the health sector. Allow me in the same way thank the leadership of our line ministry, the Ministry of Health. Remember where you started probably 3 years ago, prior to COVID-19 coming. You really led the delegation while you were Minister of Health. You used to come to the front line and actually ask us to diagnose the problem, because then there was a lot of outcry from the communities that were having challenges. People were extorting, there was abuse of office, and you asked each region, each of the levels in the system of healthcare to try and diagnose their own problems and try to solve them before the arm of the Lord reach them. And I'm glad that has been done and has led back to several of the organizations and the programs like the National Safe Motherhood Expert Committee and also local maternity care, maternity systems in the regions to try and diagnose this problem, especially for us who are in obstetrics and gynecology, where a maternal death, really, if it happens in your hospital, if it happens in your region, it evokes the media outburst and the communities where these hospitals are found. Lastly, I pray, Honorable Prime Minister, that on top of enhancing our salaries, we pray for other amenities for a complete package. Health workers are saying, yes, the salaries have come, but the working environment, I'm glad, yes, the infrastructure issue is being addressed countrywide, where most of the general hospitals infrastructure is improved now, and they are becoming regional referral hospitals. We are glad that some of the budgets for medicines and supplies in some of the hospitals, especially the National Referral Hospital and the specialized hospital like Women's Hospital, the budgets have been looked at. But how about the rest of the country? Regional hospitals, general hospitals. These need to be looked into to ensure that the medicines and the supplies are available. These staff also have challenges with accommodation. I know it's in the agenda, but could we see this accelerated to ensure that we are working close to the facilities we are serving to improve the quality of care that we are offering to the Ugandan. I thank you so much for honoring the invitation once again, Honorable Prime Minister. And I believe that the rest of the delegates are feeling the same. Thank you, and there ends my speech. At this juncture, allow me welcome the Association President, Dr. Musana, come and address us.
Right Honorable Prime Minister, we welcome you here to our conference. I will take you briefly through what we as obstetricians do. I am the president, I'm also a cancer specialist, and I work in the private sector. And I am honored to have you here, our senior consultants, Dr. Sentumbwe from the WHO, the executive members or committee members of AOGU, AOGU has been here since 1985, so it is 37 years to this year. And some of our founder members, you may have heard about them. Some are here, some are back home. As AOGU, our mission is to be leaders and offer leadership in reproductive health within the region. And we do that through clinical practice, training, that's education, research, collaborations, and advocacy. When the government came into power around 1986, you will see a lot of development that has come in. We had one university training doctors. Now there are about 5 medical schools training obstetricians. There were about 4 postgraduate students annually. Now this year, there are over 40 At the time, government started, most of the specialists were identified. At this moment, that has changed. The dividend has changed, and most of us are actually working in the private sector. At the time, there was no super specialization, but the growth and the stability has led to lots of us specializing. So at that time, there was a need for shifting many of the tasks because of a lack of doctors and specializations. But now that need for sharing some of the tasks may have been answered because of the investment that the government has made over the years. As an association, we have strategic goals. And in our investment plan, the first goal that we have is to promote excellence in performance among our AOGU members. Before I move on, I'd like to, people from the center, Kampala and the central region, just raise your hands. People from the west, Mbarara, Kabale, and the surrounding regions, please raise your hands. People from northern Uganda, the obstetricians from northern Uganda, the midwives from that area, please raise your hands. Thank you. So you will see that in every corner of the country we are represented, and this has been an effort of this has been a product of the stability. So our members are committed, motivated, and now competent. We also know that as an association, we are trying to expand opportunities for our members, and it's in line with that, in line with the government investment of the specializations, we hope that many of them can be absorbed into the public sector. Of course, our second objective is to promote provision of quality services through partnerships. This year, when they do the DHS, I'm sure you will notice there is a great difference in the number of women who are dying in facilities, not in the country, but in facilities. So most of our members have led those efforts. Most of our members are the ones leading the review of standards and guidelines, and we're the ones providing quality education to many of the Ugandans. And of course, as an association, we are doing a lot of advocacy to ensure that services and standards improve. Then, of course, as an association, it's important that we remain a strong body. And of course, part of our core is to maintain good and effective leadership at all levels. We have leaders in hospitals, leaders in the private sector, leaders on boards and other things. So we hope that we continue that and engage in government to improve the leadership. And of course, we want to remain competitive and competent. And one of the things we are doing is to make sure our members are loyal to the NPA, but also to securing the future of Ugandans, especially the women. But of course, we expect that, as Dr. Kazibe has said, we are thankful for the motivation in salary enhancements. And I hope that will go a long way into motivating many of our members who deliver the services. As priorities for the association, what is our agenda? Our agenda is to make sure that standards of care are the best in the country, and that we are doing through our expert committees. We also want to make sure that every woman and every family has access to an obstetrician gynecologist when they need them, wherever they need them. So the regions where we hope that there are no obstetricians and gynecologists, we hope that access can be improved. And of course, research to improve quality of care. Then of course, advocacy is a key issue, and at this meeting, a lot of advocacy will be done. Then of course, the forgotten problem, which is the adolescents. We had an epidemic during COVID, which exposed the teenage pregnancy rates in this country. And of course, with adolescents means that many of them are having sex. Thereby, we must prevent the unwanted pregnancies, hence a need to improve the contraceptive issues. Right, Honorable Prime Minister, the obstetrician and gynecologist is found in all walks of life. We have the administrators, as you know, we have the clinicians, we have the academics, you've seen the books written, you have the policymakers who help the government and other bodies to write policies, and of course we have the researchers. So for us to reduce the problem of women dying, but also improve the quality of life for women who are aging. When the government took over in 1990, there were just only 700,000 women above the age of 40. This year, there are 3.5 million women above the age of 40. It means a lot of things have been done to improve survival. So as women survive, we also need to extend services to that age group above 40. I would like to end my presentation there and thank you for honoring our invitation. And I would like to invite the keynote speaker, Professor Waiswa, to then deliver some of the key pertinent issues that we will require to drive an agenda. Thank you.
If you can load the presentation, please. Right, Honorable Prime Minister, I feel honored to be presenting this. My name is Peter Waiswa, and one time we were in Iga Hospital, and you told the people in Busoga that we are your grandchildren from Bunyolo. So here is one of them, and even the president. So your grandchild will be speaking to you. And if you say I'm from the School of Public Health, I'm not an obstetrician, but obstetrics is not just about cutting. Even you, if you advance, and we know you advance the issues, you can be a honorable member. They asked me to speak about securing the reproductive health future of women in Uganda. And when we look at this, I wanted to put one key message that the situation is better. The government has made a lot of improvements, and let us clap for the government. But, Honorable Prime Minister, things can be done even much better. I think that is the key message I want to pass across, that we have improved, but the room to improve and for Uganda to lead the region is still there. Now, when you talk about securing the reproductive health future of women in Uganda, the UN defines this in terms of sexual and reproductive health. And it says it is a complete physical, mental, and social well-being in all matters relating to the reproductive system. So it is comprehensive in nature, and it implies that people are able to have satisfying sex life, the capability to reproduce, and freedom to decide if, when, and how often to do so. So when we look at this comprehensive definition, there are three major issues that are important in securing the reproductive future of women in Uganda. One is autonomy and empowerment, something which the government of Uganda has worked on so much. And again, I'm sure the people in the room, you can clap for what the government has done. A second issue is actually the issue of contraception and access to abortion care. And the third issue is safe obstetric care and also gynecological care. Those are the three issues that are important in terms of reproductive health in securing the future of women in Uganda. But we know that women in Uganda and elsewhere, there are so many intricacies that make life difficult. And good enough, you're one of the champions trying to push for that agenda. Issues of inequality, lack of jobs, disease, insecure jobs, illiteracy, all of these make it very difficult to provide reproductive health, because an empowered woman is unlikely to have 10 children. Most likely they will control their reproductive health needs. So this is an issue which the obstetrician may not do much apart from advocate, that let us push the agenda of fighting poverty and also illiteracy and issues of inequity and gender-based violence. Honorable Prime Minister, I wanted to talk more on, with two slides on contraception. So The Mackay University at the School of Public Health, funded by the Gates Foundation and partners, we do a survey every year on family planning coverage in the country. And things have improved, as you can see in these graphs. But this one potentially mainly looks at those women who have unintended pregnancy. These are women who are getting pregnant when they don't want at the time. Honorable Prime Minister, from the survey that the School of Public Health has done in the whole country, it shows that almost half of the pregnancies women are having, they are unwanted. Women themselves never wanted it. And 13% of them, they wanted no more. These are looking for family planning, but they never got it. 33% wanted later. They're also looking for family planning. Honorable Prime Minister, I want to invite you that these women who want to postpone their pregnancy or want to stop, they should be able to get methods. But so far, we are doing well, but we can do better because we are not reaching half of them with services. So this is an area that I hope we can work on more. And as a result, in terms of women who use family planning in Uganda, from the survey, things have improved. Right now, it is about modern contraceptives is about 43%, which has improved from before, like in 2018, when it was about 40. But in rural areas, this is still a major problem. So we invite that we hope more can be done on issues to do with access to family planning. Now, maternal death. Honorable Prime Minister, although things have improved, we don't have the updated figure because the demographic survey has not been released. And I hope, Honorable Prime Minister, you'll be releasing this very soon because we need it for planning. But the UN estimates that currently the maternal mortality ratio in Uganda has actually improved, but it's still high. It is 375. But the range, you know, for us in science, we always say we are not sure. So we give a range for which we say we are confident. The range is between yeah. So this figure has not changed. The rate has improved, but the number, absolute number, has not gone down. And what is surprising, most of these deaths are here around Kampala. It is in Kampala and surrounding areas where these obstetricians, I think you saw the hands, most of them live in Kampala. And you need to invite them and they tell you why women are dying in Kampala despite their presence. Because maybe there are things we can fix. Because the government is here and the experts are here and the hospitals are here. But what is the gap? Honorable Prime Minister, the same for children who are dying. Now the children who are dying are around Kampala and surrounding areas. Wakiso, Mpigi, before you go to other regions. And like the president said, 1 in 5 of all pregnancies are adolescents. So we cannot reduce this number without addressing the issue of adolescent pregnancy. And because of COVID, these figures could be even higher. But they are good news, Honorable Prime Minister. When you look, this figure shows death of mothers in hospitals of Uganda. Since 2016, 2017, we've seen a 30% reduction in the number of women who are dying giving birth in our hospitals. I think we should congratulate ourselves and congratulate the government. But Honorable Prime Minister, as you can see, the curve is not coming down very fast. So there's a professor, they call it, can we bend the curve further? They call it bending the curve. How can we bend the curve further? Which is, I think, your mandate. And in absolute terms, since if you look at the figures at the bottom, in 2016-17, about 1,100 or 1,100 women died. But in 2021-2022, that number increased by about 100, from 1,100 to 1,200. So absolute numbers are increasing, although the rate is coming down. So we need to do more in these hospitals. We can celebrate, but the journey is not yet won. And where are these days happening? They are across the country. You see the red, it's all over the country that where the high rates are. But this is where also the hospitals are. So, Honorable Prime Minister, really putting a focus on hospitals is important because already people to address these issues are there. And Honorable Prime Minister, most of these mothers are dying from the things which they have always died of. Hemorrhage, they are bleeding to death. The figures show that we have improved a bit like in 2018 compared to 2022, there has been an improvement. So despite COVID, a lot of effort, and you have been the Prime Minister during this time when we are making the progress. So there is progress, but I think we can do more. Women bleeding to death. What can we do more? When I Prime Minister, one of the most annoying things is that, like the doctors have said that we increase their salaries. Even us in the university, we thank you. You increase our salaries. That's why we are serving better. But they are dying of the reason is the doctors are there, the nurses are there, the midwives are there, but they are waiting. One reason, no blood. So they refer women from Hoima to Kampala because there is no blood. No sutures. Can you imagine? A suture for a surgeon to be mobilized, and then you wait for a suture. And then we tell people, go and buy. No gloves, no electricity, no anesthesiologist. I think this is something we can do better. And talking about blood, Honorable Prime Minister, there are regions in Uganda which don't have a blood bank, like North Central, Musoga, Lango, Chigezi, Vukedi, Bunyolo, Teso. All these regions should have a blood bank. When I Prime Minister, around the time of birth, we lose about 190. If you look at the women who are dying every day and the newborns and stillbirth, they're about 190 a day. 190 is too much. When I Prime Minister, I call this war because most people are not dying of let's say COVID or Ebola. They are dying when giving birth. So we need to do a war to stop women and losing their babies and women dying. Finally, I wanted to end by these messages to you, Honorable Prime Minister, and ask from you. Number one, we say that many women want to use family planning, but we are not reaching them. We need to push the health system to make sure that they reach every woman who wants to use family planning so that they are able to use it. And maybe you could include it in the parish model, because I think it is a great opportunity to go village by village, including pregnancy prevention strategies for those adolescents who have started sex, but they need to stop having sex. So this is an important area. Number two, Honorable Prime Minister, I've told you that sometimes no sutures. I think hospitals need to be prepared better. Every day there is an emergency in a hospital. Why shouldn't they have those basic things? Basic things, emergency preparedness, maybe should be part of disaster preparedness, but in hospital, because the actual disasters are actually in hospitals. The third one is we need to prioritize building of blood banks in regions. If anybody, politician or academician, or mother bred in some of these regions, then we are likely to lose them like we do. The fourth is we need to ensure equitable access to specialists. You've seen they are training many specialists, but when our Prime Minister go to some of these regions, in fact, most districts like Niganga and the catchment area, for a population of 2 million people, there is only one obstetrician. So I think we need these specialists to go into regions and districts. Finally, we need some special programming for urban health. I mean, if people are dying in urban centers, then this is something which we can address. But methods we have used in rural areas are not going to work in Kampala. Thank you so much, Honorable Prime Minister, for listening to me. And with this, I have the honor to invite you to address the obstetricians of Uganda. Thank you so much.
Our dear leaders, our scientists, especially obstetricians and gynecologists. I'm pleased to be here. I must be sincere too. I had a lot on my table, so many competing programs, but I had to prioritize this. I bring you greetings from the President of the Republic of Uganda. He's aware I'm here. He loves you so much. Our President has a special, can I say, a special love, that urge. He believes in scientists, our President. You know the battles he has fought for you to get your salaries enhanced. And therefore, I want you to clap for him. I want to thank the Ministry of Health and you, the organizers, for extending this invitation to me. Reproductive health matters, I want to assure you, are close to my heart. Why? Because I have grown from areas where almost we lived in a situation of lack. And therefore, I have seen it all. I have seen pregnant mothers die just like that. And therefore, I am obsessed. It is close to my heart. Good reproductive health is an important component of life for ensuring that people are able to have a satisfying and safe sex life. The capability to reproduce and the freedom to decide if, when, and how often to do so, but also to be able to do so safely. To maintain one's sexual and reproductive health, people need to access. They need access to accurate information and the safe, effective, and affordable, together with acceptable services. These services, you are aware, include family planning, antenatal. You know, antenatal care is key. Emergency obstetric care, and many others. What do we see? I can give you an example of Gombe, where I was a few months ago. Gombe Hospital is an old hospital. You have talked of lack of infrastructure. Do we have infrastructure problems in Gombe? Yes or no? It was a Sunday, I remember this year. You must have seen these things on TV. But before that, I got, during Prime Minister's question time, a question from the woman member of Parliament, Butambala. Madam Prime Minister, can you tell us why our pregnant mothers are charged highly to deliver in Gombe Hospital? Can you tell us why all pregnant mothers who go to Gombe to deliver are taken through a cesarean section at a rate of 60%? So I said it can't be. So one day on a Sunday, I said, let me go. When I went to Gombe, they did not expect me to be there. What I saw is that there were 53 women who had delivered in that hospital. Out of 53, 48 had undergone a cesarean section. 48, Bonanga Babasazi. You, the doctors who are here, we have a problem. How many doctors were there? There are 7 doctors in that hospital. None of them was there. The one who was there was an intern doctor. And he was the one who was, I found him on table that day. How many midwives were there? I found only one midwife out of 27. Only one. And I want to talk about these issues candidly. How many clinical officers were there? There was none out of 10 clinical officers. How many nurses were there? Out of 20-something nurses, there were 2. They had these people who called themselves volunteers. So the volunteers, you expect people to work without pay? They definitely have to charge, isn't it, to survive? So the hospital was left to volunteers. Who were the MS of the hospital? The DHO. The DHO was the acting MS. What did I discover? All the houses that are supposed to house doctors and midwives and nurses, this is what I found. The cow of Butambala was staying in the houses of health staff. The DHO, the RDC, so the doctors kept quiet. They did not resign. They kept in their clinics in Kampala. But we are getting our salaries. Colleagues, I think we have a problem where some of our health staff feel neglected, but they keep quiet. who was supposed to help the medical officers to have their issues addressed. That would be the DHO. But the DHO was also the NS of the hospital. And the DHO would go to the hospital only on Mondays. These other days, I think he's in Kampala. He also owns a clinic in Kampala. The president has enhanced our salaries. Colleagues, even if they add you and you have maybe 50 million per month, if these are the small issues are not addressed, these doctors will not work. What did we do? I directed that the MS, the acting MS, who is also the DHO of Butambara, should relinquish one position, and that is being MS. I also told him, you are better placed. I chased them from the houses of doctors and nurses, and they left. So I organized another meeting where everybody was present, and they were like, now the communities, the health staff together with the community have now inculcated the spirit of, togetherness. How much money is needed for a DHO to hire a house? That demotivated our staff to the level of resigning their duties. They did not resign formally, but they resigned. Are we together? I know some of you are supposed to support, supervise. Some of you are supposed to supervise. And some of you are also doctors, and you know what you go through. The reason why we are leaders is for us to handle those small issues that affect you. But sometimes we are denied information. If it was not for the member of parliament, I wouldn't have known. When I went back, I was told that at least 38% of our pregnant women in Gombe at that material time had undergone through a cesarean section. At least that one is a big achievement. The other thing they wanted, in fact, when we went in that meeting, I had stopped, you call it, where people get services for free, and is where people pay a small cost sharing sort of, it's called what? Private clinic, private wing. So when I went to Gombe, they had a private wing first time. But people were sleeping in the same ward. The one who is in the private wing, in the same ward, they would provide a small curtain. You call them the screens. That one for the private wing, they would provide a screen. That person would see doctors. That person would get medicine from the same facility, from the same stores. That person, that would be a special person in the screen. So that is a private wing. I told them to hell with your private wing. And when I went back, they said, Madam, you stopped a private wing. Now we cannot even buy a glove. So what I did, I came to the national medical stores. Do we have anybody from there? NMS? So let me see the deliveries. The deliveries were like overwhelming. You know what is expected from national medical stores? 2 a district hospital. So colleagues, there are two things I want us to differentiate here. How you people who are here, would you feel you are in the same ward? Somebody has been provided with a screen, like a curtain. Whoever is, all the care is given to that very person. But because for you, you do not have money, you see doctors, all of them going to that one in the same ward, and that is a private ward. So I request that those of you who are charged with the responsibility to help us support, supervise, to monitor, to do your job. Our people are looking at us differently. The acute problem of sexual and reproductive ill health is a leading cause of death and disability for the survivors, for women and girls of childbearing age. The underlying root or underlying cause of these problems are known. Some of them are poverty, like I've already told you. The harmful gender power relations, the negative traditional and cultural practices, ignorance of how to prevent or address ill health, all the root causes of young people and women are extremely, we find them extremely vulnerable. We are aware that our policy is that traditional birth attendants were stopped, I believe, was it in 2012? Swear back. But our people continue to go to traditional birth attendants. You are aware that they go there. They are delayed there. By the time they come, sometimes it is too late. What has government done? Government has a policy of providing a health center 3 per sub-county. The other day they gave us a report, the Ministry of Health, that we are almost 80%. 80% is a very good mark, according to me. And we are saying these facilities should be in a radius of 5 kilometers. And I believe we are almost there. And there are those that are going to come on board this financial year. There are like almost 200 health facilities that are almost complete. And tomorrow I'm going to be in Kakumino to add on 4 out of 24 health facilities where we have a midwife, a clinic officer, who can help us deliver these mothers. Government, to me, government has tried. There is a lot of improvement. I believe these trainings will help us and help you, the medical professionals, to navigate through this. Yes, we have enhanced the salaries. But is there a value for money? When there is no doctor, a full day, no doctor, there is an intern doctor. And that day, one woman had died in his hands. So you get what I'm talking about. So I believe there are some issues you have talked about which we need to also, as government, put in place. But we also need you to behave professionally. I believe a professional doctor, a professional midwife, the satisfaction you get in your life is to see that you have saved life. I believe that is it. any professional. There are people who say, Nabanya, how ochikorotia? We see you here. For me, the fact that the president picked me out of 45 million Ugandans is enough for me. I don't need anything to motivate me. It's enough for me to fly everywhere. And I believe the fact that God chose you to be a doctor, a gynecological doctor, is enough for you to move, not money. Yes, we need money because you need to also survive. But even if we give you billions of shillings, when leadership gaps still exist in your facilities, like I've narrated, those doctors will not serve our people. So you, the inspectors of our facilities, please do your job. Identify these gaps, bring them to government, and then we also do our job. Because like I've told you, the cow is no longer staying in that health facility. I told them, go out. And I did not need any professionalism or anything. It was automatic. I told them, Vemu, and they left. I said, if you don't leave these staff houses of our health staff, and I come back and find it, I will chase you out on TV. Within 1 day, they had gone out. 1 day, they had left. And there is some kind of improvement. And our health staff no longer absent themselves from duty. And so I have been following the report of our president, who says 6,000 women continue to die. By the way, in the developed countries, a pregnant woman or delivering mother dying is like a taboo, isn't it? What is it that you need government to do to stop this? Yes, government now, you talked of poverty. Government has embarked on a program, you know, the Paris Development Model. We have a lot of hope that this program will be nurtured to help our people to come out of poverty. We have also tried to educate our Ugandans. You know, an educated woman, you know, when you're educated, how you can be empowered. You cannot just produce anyhow. An educated woman cannot be like the other one in the village. No. So education is one way of helping our people change. I have seen you display a number of things here, but do our people know? Information is power. Do our people know that you have those many contraceptive gears? How do we disseminate the information to our people? Because at the level of the Prime Minister, there are certain things I didn't know. If the Prime Minister doesn't know, what about the other woman in Kamasenene? So there is need for us to give information to our people. Government continues to focus on upgrading health center 2s to health center 3s. And I believe we are almost 98%. And we are now going to embark on upgrading health center 4s, health center 3s to health center 4s. Then we shall also upgrade health center 4s to hospitals, especially in those districts where we don't have. But the president, remember, some time back, directed me to recruit doctors at every health center. Do you remember that promise? We need to come up with a strategy, you the professionals, on how to do this. Because taking a doctor to a health center 3, maybe when there are many things which are lacking, they may be there redundant, isn't it? So help us to put in place certain things which we can follow, we, the policy makers. And lastly, as we noted recently, younger people are seriously affected by HIV. You talked about it. And every year, many girls face unintended pregnancies, exposing them. You know what mama is doing nowadays? We have a full program of helping these mothers, these younger mothers, to look after their children and go back to school because they did not complete. Why? Just because there was a lockdown. And people decided to move and enjoy our girls, exposing them to risks during childbirth or unsafe abortions and interfering with their ability to continue with their studies. I'm told that the theme for this year's conference is, this conference is number 17, is securing the reproductive health of a woman in Uganda, is therefore timely and urgent. The objective of this meeting, I'm told, is to share experiences, discuss challenges, highlight successes, and areas where you need to scale up. I'm told you also want to map strategies for improving the reproductive health of women in Uganda. I want to assure you that the government of Uganda is committed to continue supporting the promotion of reproductive health of our people. I thank you all for attending, and I request that all that you have come up with, let it be channeled through the right procedures. I know the Ministry of Health is doing a good job, and I want to thank them. I look forward to the outcomes that will come from your deliberations for action. I thank you once again for God and my country.
Photograph here. Can we representation?
I am our doctor. Let me ask this. You have made us remain on this. And for you are not putting them on. Which is which? Who is fooling who? For you, the doctors are not putting on this. For us, we are putting on masks. Okay.
The group photograph. Honorable Prime Minister, I wanted to say that we follow the advice from the Minister of Health, the technocrats. We are fully vaccinated, and the guidance from also CDC now. So, national anthem, please. Can we? First, we shall have the organizing committee and the scientific committee members take the photograph, and then the other members will join the next group. That's all done. Take this. Prime Minister Rachifana, you know that Dr. Waso, I don't see you here. Please step forward. Please come forward. Dr. B is ready to sit. We have that other chair. Please come forward. And this all of us? Okay. The other group, are you done? The other group, associate members, dear gynecologists, can you step forward? We can do it by region probably, if you don't mind, for the next 5 minutes. So associate members, please come. Our SHOs, please come. I'm saying associate members, SHOs, and all these we shall give you a chance for the next 2 minutes quickly. Associate, please come forward. Yeah. No, take my face to man. You take my face. Hey, get my face.
Members, those of you who are here are all medical professionals. And I know you know what I'm going to talk about. I know all the policies that we get are initiated from you who are, you know, on ground. Why is it that we still put on masks in Uganda? Talk about it here so that this can inform the National Task Force, the Director Medical Services, so that we come up with a policy.
Right, Honorable Prime Minister, it would be very illegal of us to speak out when we have proper channels or the right channels to channel this technical information. We are always invited. Yeah. Can we have other gynecologists please come for this moment? Spire, please come. You will not stood with the Prime Minister for a while. Can you please come? And Kato, your team, Quickly, she needs to move. Secretariat, Stella, please come forward. Quickly. Thank you so much, Right Honorable Prime Minister, for this moment. As you can see, we are so overjoyed. Yes, please. Dr. Wanyama, I don't see you here. I have not seen you. Come again. And then one last one, the elders, AOGU, please. Our seat of wisdom, please. You'll be the last ones to take a picture with the. No, not yet, sir. Not yet. The last one will be for the elders of the association. If elders, please. Dear elders, come for the last. Dr. was expecting to be on a seat here. The associations. Habo Mugisha, I don't see you coming. Dr. Habo, please come. Habo Mugisha, please come forward. Thank you so much. I think we have really enjoyed the company of our Right Honorable Prime Minister. And if there are any questions to whisper to her, please feel free. Dr. Habo, at the back here. Any information? Am I also an elder? Okay. Dr. Waswa, oh, good. Dr. Olive, oh, wonderful. Okay. Prakash, I don't see you here. Prakash? Okay. Thank you so much. Prakash, please come. This last, very supportive. He's a very long-serving gynecologist. I don't know why he's hiding. Prakash, Andy, please step forward. Let's start with you. Stand here. Malcox, Mali, please come. Come for this moment. It's coming. And that just the mask, please. We discussed this at length. Add just the mask, please. Thank you so much, members. We shall resume with the program as it's running. Yes. For the few of us, we shall accompany the Right Honorable Prime Minister out. So,
ladies and gentlemen, thank you very much for many of you members received a message on WhatsApp. It's a survey which we initiated with support from FIGO about how we can how we can improve services to you as our members. It's a short survey about how we would want us to participate more effectively as the leadership of AOGU. It's a very short survey. We request that you complete it. We have sent it by WhatsApp, but we can also send it by mail for those of you who want to send it by email so that we can use it to plan. Remember, the next phase of the implementation of the APMM project up to March is to strengthen mainly the association and to see how we can work together as colleagues. And it's through initiatives like this that we establish the regional chapter. So we want to learn more about how we can be more relevant to you as members. The other thing I wanted to say is that they are our partners at the back there. Please visit their stalls, interact with them. They have very many good products which you can use in your health facilities or the service delivery points of care. There are also very nice materials. I've seen a very nice book by one of our colleagues. I can't call him young because when I looked at his head, it'll look like mine. Dr. Mujenyi has a nice material. Please go to his stall and look at it. And there are many others. Thank you very much. We're going to have lunchtime for about 40 minutes. In the same place as yesterday, please get a coupon. We go for lunch. We come back to around 3 p.m. Or a few minutes past there, and then we have the lunch. When we come back, we'll have the Vela session about postpartum hemorrhage. So we are not bad off with time. And at the end of the session, there is a cocktail. Please, if you want to visit the city now, for those people from Moroto and Chisoro, you can visit the city, but come back for the cocktail. They are very nice buildings which have been put up since you graduated in the 60s. Thank you very much. Yeah, it's worldwide. It's true. We were the first announce and then we can see and then we have in my example. There are two other sessions. This one. It's here with the this one. Every year it's in the charity. You have got the now what tabula what maybe you are going to be anywhere. They never take up. So let's have lunch so that we come back at about 3 p.m. so that we complete the remaining sessions. Yes. Yes.
And there's a complication, which is ulceration. So this affects quality of life, as we shall see, of women. Pelvic organ prolapse is one of the components of the pelvic floor disorders. Among some of these, we have things like fistula, anal sphincter injuries, and other forms of stress urine incontinence. And has prevalences which are in Uganda, we don't know the exact prevalence, but worldwide we have a prevalence of about 3 to 50%. And as we have seen in those high grades, it poorly affects the quality of life of these women in many aspects. That's the physical, where they cannot work, they cannot walk; social, where they cannot socialize with other people because of the smell which is coming out of when there's ulceration. Then the emotional aspect also has sexual problems where they have to reduce the prolapse in order to have coitus, and if they have the coitus, it's usually painful. Surgery has been found to improve the quality of life of these women in other countries. And the treatment can be both surgical or conservative, but we don't have the conservative methods readily available like pessary, so we end up having only surgery. But surgery comes with some of risks like recurrences, and recurrence rates of about 13 to 58% have been reported in other countries. So our objectives were to assess the quality of life among women with symptomatic pelvic organ prolapse before surgery at Mara Regional Referral Hospital, before surgery and after surgery in all the social domains. That's after 1 year of doing surgery. And then to determine the recurrence rate and the risk factors for recurrence 1 year after surgery of pelvic organ prolapse. In the methods, we had a cohort, and we recruited every woman who was diagnosed with symptomatic pelvic organ prolapse and was scheduled to have surgery. And we did this between 2018 December and 31st December 2020, about 2-year period. We excluded any woman who had had a previous surgery for pelvic organ prolapse and it had failed, and those who were pregnant, and those who had other coexisting pelvic floor disorders, like fistula or anal sphincter injuries. And we followed up these women consecutively for a period of 1 year, at 2 months, at 6 months, and at 1 year. That's when we came up with the final follow-up. And we One year we did a quality of life assessment after surgery, and we did this using a King's Health questionnaire. And we calculated the scores in all aspects, the domains of life, and got the overall quality of life score. And if someone had a score of greater than 40%, we took that as having a poor quality of life. We did multivariate analysis for get the risk factors for recurrence. The results, we had a total of 120 participants who were enrolled in this study, and we lost 3 to follow up. And it wasn't surprising that the mean age was about 55 years, as expected in these women with pelvic organ prolapse, and most of them were peasants. The commonest stage was the high grade of the prolapse, which is stage 3 and stage 4, were the commonest stages of prolapse. We did surgery in the 117 patients, and we found that the commonest surgery we did was a vaginal hysterectomy, then went into the pararectal space to look for the sacrospinous ligament, and then fixed the vault, vaginal vault, onto the sacrospinous ligament. And we didn't have so many intraoperative complications apart from rectal injuries, some few rectal injuries, hemorrhage, which required transfusion, and bladder injury. And the commonest postoperative complication was vaginal calf sepsis. We assessed the quality of life before and after. So before, we found that overall women with pelvic organ prolapse had a poor quality of life, as we have seen. They had an average score of 45.5%. And the domains of life which were affected by pelvic organ prolapse were mainly the physical, social, emotional, and sexual life domains. But after surgery was done, we found there was a marked improvement in all domains of life, especially the physical, social, emotional, and sexual aspect of life. And this was similar to what has been done elsewhere in the developed world. Determining the recurrence rate, we had 32 women developing recurrence at 1 year after surgery, giving us a recurrence rate of about 25%. And when we followed up these women at the different follow-up times of 2 months, 6 months, and 1 year, we found that the recurrence rate increased with follow-up period, but most recurrences occurred within the period of 2 to 6 months. Risk factors for recurrence, we found that age less than 60 years, a woman who was less than 60 years was most likely to get a recurrence, and those who suffered post-operative vaginal calf infection were more likely to get recurrence of pelvic organ prolapse at 1 year after surgery. So we conclude that with the quality of life among women with pelvic organ prolapse is poor, but we see that surgery as a mode of management improves the quality of life in these women. And recurrences are common. 1 in every 4 women who have had surgery suffers a recurrence. And young women who are less than 60 years and those who suffer postoperative vaginal calf infections are at risk of developing recurrence of pelvic organ prolapse after surgery. So we recommend that we need to scale up surgery in these women such that we can improve their quality of life. And not only do we give them surgery, we have seen that all aspects of life, mainly social and emotional, are also affected. So surgery alone may not be enough to improve their quality of life when they have these emotional problems. So we need to offer them psychosocial support. And we also need to implement measures where we reduce the risk of postoperative vaginal calf infection in order to reduce the recurrences. And since we see that recurrences are more likely to occur in women who are younger, probably because they carry on with the other functions, the other aspects of life, heavy work, delivering, so probably the pelvic floor still weakens. So we need to offer them probably conservative means of prevention, conservative means of management of pelvic organ prolapse other than surgery in order to reduce the risk of recurrence. This work has been published. 2 papers came from it. One of them is that the impact of surgery on the quality of life of Ugandan women. with symptomatic pelvic organ prolapse, and another is risk factors for recurrence of pelvic organ prolapse after vaginal surgery among Ugandan women in the International Urogynecology Journal. So I want to acknowledge all those people and teams. I want to thank you.
Thank you, Dr. Musa, for keeping time. Please note down your questions you'll ask at the end of the discussion. I also would like to invite Dr. Okelo Moses, who is going to be presenting on behalf of DKT, to come up to the front. Next on stage is Dr. Ainomugisha Brenda. She will be presenting risk factors for iatrogenic genitourinary fistulae following cesarean section at Mbarara Regional Referral Hospital. Dr. Brenda, you're welcome. Thank you. Good afternoon. Good afternoon. Yeah, so I'm Ainomugisha Brenda, a gynecologist from Bara University, and I'm presenting work that we've done in the department over the years about risk factors for iatrogenic fistula following cesarean delivery, and that's the team of the co-authors. So generally, there's an upward trend in the cesarean section rates across the globe. This is ideally a positive because it's a marker of improved maternal care, only if it's without effects. But unfortunately, like we have heard from the 12-year experience at Bara University and also the rising trend of iatrogenic fistula, there is risk that comes with the increased rate of the cesarean section, and that is occurrence of iatrogenic fistula. So cesarean section is the most commonly performed operation in Uganda, but it also contributes the highest percentage of iatrogenic fistula. As maybe most of us know that an iatrogenic fistula is an iatrogenic genitourinary fistula is an abnormal connection between the urinary tract and the genital tract resulting from a surgical procedure. And there are some already studied and documented risk factors for iatrogenic fistula following a cesarean section. And these include presence of adhesions, like in previous surgeries, obstructed labor, the position of the presenting parts, birth weight more than 3.5, and also the low cadre of surgeons performing the procedure. So in this study, our objective was to determine risk factors for iatrogenic fistula among women with genitourinary fistula that had a cesarean delivery or cesarean section in the delivery leading to the fistula. So we did a retrospective review of patient charts of women that had been admitted with genitourinary fistula at Mbarara Regional Referral Hospital who had had a cesarean delivery just before they developed the fistula. So for us to classify someone as iatrogenic, we consider those that had ureteric fistulas, vescocervical and vescouterine fistulas, and then the other women that had genitourinary fistulas that were none of those, that is the urethrovagina and vescovagina, we classified as obstetric fistula. And what did we find? Most of our participants, the average age was 32 years. Most of them were from Western Uganda. That is where our facility is located. About 95% were in informal sector, and most were married, and most were Christians. In the baseline obstetric characteristic, most of our participants were multipara, and about 78% were having a primary cesarean section. And for those that had repeat cesarean section, most of them had just one previous cesarean section. And for the indications, mainly the women that had obstructed labor as an indication for cesarean section that ended up with iatrogenic fistula. Medical factors, most of these women had had their cesarean section at a general hospital, and they had been operated on by a general practitioner or medical officer. When we did the multivariable analysis, 4 factors turned out significant, and that was parity, type of cesarean section, cadre of the surgeon, and the level of the health facility. Mothers who were grand multipara were about 6 times more likely to end up with an iatrogenic fistula at a cesarean delivery as compared to those that were prime paras. And those that were having a repeat cesarean section were about 4 times more likely to end up with an iatrogenic fistula as compared to those that were having a primary cesarean section. Mothers that were operated on by an intern doctor, about 5 times more likely to end up with an iatrogenic fistula compared to those that were operated on by a resident. And I needed to say this, that we actually had almost no operation, primary cesarean section done by a specialist. So we're not sure whether specialists were not working or they were not documenting. So that is why we are using the residents as our reference group. And then the level of facility, those that delivered at health center FOS were about almost 5 times more likely to end up with an iatrogenic fistula as compared to those that delivered at a regional referral hospital. So we recommend adequate surgical training of intern doctors and medical officers, as we notice that they are doing most of the work, but they are also causing the problem. And also the decision making on what operation is done by which cadre, because we are already seeing that it's mainly the obstructed labors, the mothers with repeat cesarean sections that are ending up with the iatrogenic fistulas. So these are the ones that could be prioritized for the higher cadre of medical professionals. And then we recommend that cesarean section should really be done only when it's clearly indicated, because we have seen that most of the mothers that had iatrogenic fistula were having a primary cesarean section. Whether it was indicated or not, we can't guarantee. And then repeat cesarean section turned out significant at multivariable analysis. So if you have 1 scar, there's risk that you would get an iatrogenic fistula at your next delivery. And then we also saw the grand multiparas being more likely to end up with the iatrogenic fistulas as compared to the prime paras. So maybe if we don't get to the grand multiparity, maybe we would also reduce on the iatrogenic fistulas by embracing contraception and planned family size. Thank you. I will acknowledge Mara University and mentorship of Dr. Musa Kayondo, Dr. Rao Foundation in Switzerland that is supporting me for the fellowship. And those were my references. Thank you.
Thank you, Dr. Brenda, for keeping time and being loud and clear. Please reserve your questions for the end. At this juncture, allow me to invite Dr. Moses Okello, who will be presenting on behalf of DKT, DKT's contribution to sexual reproductive health in Uganda. Dr. Okello, you're welcome.
Good afternoon. Good afternoon, everyone. My name is Dr. Moses Okello. I'm a public health specialist and also a program management specialist. I know I'm a MIDI specialist, so most of them will ask, do you have training in all those specialties? Yes, at master's level. So also when I look around, I see colleagues, I see mentors, I see Dr. Olive, whom we have worked with closely in establishing most of the policies that you're enjoying. I see my classmates, I see my students. So for those of you who come to UMI to do management courses, we may cross paths. So I founded the health service management course in UMI. So probably when you decide that your promotion is due and you need that training, you may come and interact with us. So what is DKT? Most people ask, and I'll tell you that DKT is an organization founded as a result of friendship. Our founder, Phil Harvey, went to India way back around the 80s, and he worked with the Assistant Commissioner of Family Planning. And when he was there, this gentleman died at a tender age of 42 years. So Phil Harvey said, I need to go back to Washington and create an organization that I'll name in memory of my good friend, the Assistant Commissioner of Family Planning in India. And so the name DKT came to be, and DKT stands for Damatra Kumar Tiaj. So it's a name of an Indian Assistant Commissioner of Family Planning. So for those of you who have never interacted with DKT, it's one of the largest international organizations that provides contraceptive services to most of the countries in the world. We have 30 years of experience in social marketing. And when we talk about social marketing, we talk about 4 things: that you must have products, you must price them appropriately, you must promote them. That's why you're seeing billboards of Kiss, billboards of Lydia Postpill and all that. And then you must ensure that they are taken to the right places: clinics, pharmacies, and drug shops. In Uganda, we came in 2017. And so we're working with the Kenyan team, and we have recently opened office in Southern Sudan. Our global impact, as of last year, we had 52 million CYPs. We had 12 million unsafe abortions averted. And then the maternal death was at 49,000. As a gynecologist, you need to know that any successful outcome in gynecological practice is measured by 5 impact indicators. Either you're reducing morbidity, mortality, or you're increasing the quality of life, as you have just presented, or reducing the disability, or you're actually increasing contraceptive prevalence. So we measure that using CYPs. So it's very important that you know that a woman's freedom to determine her reproductive health destiny is one of the most impactful decisions she can make for herself, her family, and the society. And the Prime Minister was here talking about the importance of this. But you know that as a country, we need to harness what we call the demographic dividend. So that means we need to invest in 4 things. 1, invest in health. 2, availability of contraceptives. 3, we need to invest in quality education, not just any education. And then finally, good governance, like the things that we saw in Gombe. So that speaks to the theme that if we are to secure the reproductive health future of women in Uganda, we need to invest in those 4 things. Where is DKT found? First of all, we're in 24 countries globally, and our footprint is in 90 countries. So some of those countries are in there. Our global impact, just on the right side of that slide, by 2020, we had that. The updated results are quite better than that. So that shows you that to complement quality of care, you need the supply chain to be functional. And the Ministry of Health recognizes the fact that not only do we need to have national medical stores, we need to have what we call the alternative distribution for family planning and all that. But most importantly, there are days when GMS will not have these commodities. So you need the private sector to complement those roles. And that's where DKT comes in. So the question would be, what have you done for Ugandans since 2017? And I'll tell you that if you look at that curve, we are seeing a trajectory of our contribution to CYPs in the products that we are giving out to the country. And that means that any CYP figures that have been documented from 2017 to date, you can actually see that DKT is leaving a big footprint in the Ugandan section productive health indicators. And how have we done that? DKT has 3 brand families. We have what we call the KISS brand, we have the Lydia brand, and then the Care for maternal and reproductive health. So KISS is what we call a specialty condom. And when we meet the National Condom Coordination Committee, they usually ask us, so how are you encouraging young people to come back to condom use? And we tell them that we've brought these specialty condoms. Kiss Classic, Kiss Strawberry, Kiss Chocolate, Kiss Passion Fruit, and then the Kiss Studded. So that's an innovation. And you can see that people are tired of the other smells of condoms. So now we are saying we are revolutionizing the use of condoms in the country. And so we are making our footprint in that area. Our second brand family is the Lydia Post Pill, which is emergency contraceptive. We have Lydia Fine, which is a combined oral contraceptive. And coming soon, we have already submitted the dossier and registered with the National Drug Authority. We shall be having the Lydia injectable. So that means we will be bringing what we call a full spectrum of sexual and reproductive health commodities to the country. And so we need to continue supporting the private sector, but also complementing what government is doing. So as DKT, with our 30 years of experience, surely we believe that we are going to contribute to this theme, but most importantly, help people like you who are going to run private practices. And you don't want to be seated in your clinic carrying commodities that are embossed government of Uganda, not for sale. So we are giving you those options, that's that you'll not be embarrassed. Then we have the Lydia IUDs, which I think you've interacted with. And then we have Level Plant. We have Cyana Press. And then in the Kare family, we have our Miso Care. We have the Combi Pack, which I think I'm reliably informed will be in the essentials drugs list by next year, because I saw it in the draft. So it's most likely that it will sort out your intrauterine fetal death problems. And then we have the MVA kit, which we are the sole supplier of this kit. So ladies and gentlemen, with those commodities, we've been able to contribute to sexual and reproductive health in Uganda. And I want to end by saying that if a woman comes to your clinic or hospital and she leaves without you talking about family planning, you've let that woman once. If she goes back and gets unintended pregnancy and contributes that statistic of 13 or 33% that Professor Weiss was talking about, you've let that woman twice. Should she undertake unsafe abortion and probably dies, you have let that woman thrice. So don't be that gynecologist or obstetrician who lets down Ugandan women thrice in one go. Thank you very much.
Wondering whether the condoms are going to be kissed, to be having all those flavors, but thank you for the work well done, DKT. I think the presentation is appealing to the youngsters, okay? Even the adults, okay. Up on stage, we'll be having Dr. Kajavangu Rogers, who'll be presenting management of uterovaginal fistulae, 12 years experience of the urogynecology team at Mbarara Regional Referral Hospital. Rogers, you're welcome.
Thank you, Dr. Susan. Good afternoon, delegates. As rightly introduced, I'm Dr. Rogers Kajawangu. I serve at Mbarara Regional Referral Hospital with a team. So I am here to present some work that we have done, management of ureterovaginal fistulae. I want to share our experience from managing patients with this condition for a period of 12 years. Those are the co-authors, and 3 of them here, while others are not. Okay, so a ureterovaginal fistula is a connection between the ureter and vagina, which is abnormal. The two are not supposed to be connected. And we know that most of the ureterovaginal fistulae are iatrogenic, and they happen when there's injury during pelvic and gynecological surgery. If diagnosed intraoperatively, they can be managed immediately. The challenge is that most of them are diagnosed post-operatively, and they are severely disabling because the patient will have incontinence, infection might result, and there will be a lot of discomfort. Unfortunately, we have very few fistula surgeons in Uganda. I missed the opportunity to ask the Prime Minister to also invest in training surgeons of fistula to increase on the number. So there are few fistula surgeons, but even among them, repairing a uterovaginal fistula is an extra skill that needs to be learned in a special way. So in doing this work, sorry, the pointer is playing me. Yes, in doing this work, we set out to determine the burden of uterovaginal fistula among the patients we were working on in our fistula camps in the different sites that have been mentioned earlier. But we wanted to focus on the uterovaginal fistula treatment outcomes among those patients. So we did a retrospective review of our charts for the patients we had managed for the period running from 2010 to 2021. And this is what we found. We found that out of the 477 patients we had operated, 47 of them had uterovaginal fistulae. And this constituted about 10% of that load. So most of these patients who had uterovaginal fistulae were unemployed. They were more than 35 years of age. Many of them were married. It was mostly multiparous women who were affected, and they had had incontinence for 1 year and more, for at least 1 year. When we looked at the operations where we thought these injuries could have happened, we found that most of them had occurred during cesarean section, as Dr. Brenda has presented, but also a few occurred during obstetric hysterectomy, such as that follows ruptured uterus and even puerperal sepsis, and others that occurred during gynecological hysterectomies due to benign gynecology pathology like uterine fibroids and cancer. Then we wanted to also know the levels of the facility where these injuries were happening, and we found out that it was mostly at general hospitals, and the surgeons at the operations were mainly medical officers. I wanted to describe our management standard. We usually make a clinical diagnosis in all the cases of this condition because we do not have cystoscopy, and intravenous pyrography can be done, but it has to be done privately, and most patients cannot afford. So we take history and find that the patients have urinary incontinence. Then on examination, for many of them, you find dermatitis from the urine. We do a dye test which is negative in the case of uterovaginal fistula. And we usually follow this with a 3 swab test. And in the 3 swab test, we put 3 swabs, one in the upper vagina, mid vagina, and lower vagina. When you find that the highest from outside going in is wet, and these others are dry, and none of them has dye, then most likely the patient has a uterovaginal fistula. In a few of the patients, we are able to do ultrasound scan showing hydronephrosis and dilated ureters. Then our surgery, our standard of surgery, we used open surgery for all these patients, using the abdominal route in almost all of them. After opening the abdomen, we usually explore the ureter to determine its path and where the injury might have taken place. And then we do a cystostomy after mobilizing the bladder, and we reimplant the ureters into the bladder and leave a stent in the ureters. We use mostly pigtail stents, which we leave for a period of 2 weeks, although there is literature suggesting that the stent can stay for as short as 5 days. So since we do not have cystoscopy to remove the ureteric stent later, we attach it to the Foley catheter so that when we are removing the Foley catheter, to come out with the stents. So using this management standard, these are our outcomes. 45 of the 47 patients healed from the fistula with continence after the surgery, whereas 2 failed. We had to repeat the surgeries, and for one of them, the ureter was very short. We had to do a Bowari flap. Looking at the complications, most of them did not have any complication, but 5 of them had hemorrhage after the procedure, and 5 developed wound infection, and the 2 I talked about had repair breakdown. So in conclusion, the rate of uterovaginal fistula is high. 10% cannot be underestimated. From our experience in managing these patients, we think that if you do not have access to IVP, do not give up. You can still make a clinical diagnosis and help these poor women. The transabdominal approach of ureteric implantation, in our experience, is highly effective. But most importantly, because we think that most of these injuries were iatrogenic, we are, like other speakers have done, encouraging training of the general practitioners and even intern doctors in proper surgical skills to prevent these injuries. There is a program called ETO, or SOO, Structured Operative Obstetrics, which was rolling out for interns and residents. We are hoping that this can be extended to include all the doctors who do surgery on our mothers. This picture shows part of our team, and on the side is one of the surgeries for uterovaginal fistula. I would like to acknowledge the Medland Medical Missions, which supported my training in urogynecology and pelvic floor medicine, and the Urogyne team headed by our mentor, Dr. Kayondo Musa. It has the training in Barara started about 3 years ago, and 2 of us have completed the training and 2 other fellows are in training, and we hope that this will continue to increase on the number of fistula surgeons. As I mentioned, that this is a challenge. Thank you, ladies and gentlemen. Enjoy the rest of the presentations.
Thank you, Dr. Rogers and the Mbarara team for the work well done. I think Dr. Kayondo deserves a hand of applause. Thank you very much. We have another member added to our session. Allow me to invite Dr. Lwasa Joel, who is going to be presenting diagnostic accuracy of shock index as a screening tool. Sorry, Dr. Asen. Sorry. I missed Dr. Asen. We are going to have Dr. Lwasa, please come up on stage. We are going to have a qualitative. Okay, no, it's not your time. Sorry. We are going to have a qualitative study identifying the perspectives of health workers and potential clients on postpartum long-acting reversible contraception in Eastern Uganda. And this is going to be presented by Dr. Asen Kamwesije. My apologies. I had just perused to Dr. Kayondo Musa and I forgot you. You're welcome.
Thank you very much, Chair. Like she has already introduced me, I'm Asen Kamwisije, and I'm an obstetrician and gynecologist. I work with Mbale Regional Referral Hospital in Eastern Uganda. I'm happy to be here and to present my protocol. This is work that is yet to be done in the Eastern region. I would like to recognize the presence of most of my teachers and mentors while I was an undergraduate and postgraduate. And in a special way, I would like to recognize the presence of Dr. Jolie Beeza, who supervised my work as a postgraduate. Thank you very much. So mine is a qualitative study identifying the perspectives So it's a qualitative study identifying the perspectives of health workers and potential clients on postpartum long-acting reversible contraception in Eastern Uganda. Those are my mentors, and two of them are here with us, Dr. Milton Musaba and Dr. Marlene Wilcox. So that is our outline. So operational definitions, postpartum period, we are going to look at it as the time from delivery up to 6 months post-delivery. And the reason why you're looking up to 6 months is because after 6 months, we know that lactation amenorrhea can no longer be relied on as a method of contraception. So in the background, postpartum family planning aims to prevent unintended and closely spaced pregnancies during the first year following childbirth. And postpartum family planning is one of the highest impact interventions to avoid increased adverse maternal and neonatal outcomes such as maternal anemia, low birth weight, preterm deliveries, and so on. Long-acting reversible contraceptives, which we are calling the LACs, provide effective contraception for extended periods without requiring user action. And we have two main forms, which are the implants and the intrauterine devices. Both the intrauterine devices and implants can be inserted in the immediate postpartum period. Postpartum insertion of these devices allows women to have a family planning method in place before they leave the hospital. And this is particularly important in our rural settings where it is sometimes difficult for mothers to return for family planning services. So the problem statement, women in the postpartum period are among the groups that have the highest unmet need for family planning, up to a tune of 67%. Despite the safety and efficacy, the long-acting reversible contraceptives remain underused in Uganda, especially in the postpartum period, and they only account for up to 7.8% of all the methods that are being used. And there has been very little research on experiences of patients and health workers in Uganda regarding postpartum long-acting reversible contraceptives. So in the justification, research has shown that spacing of more than 24 months between pregnancies decreases maternal and under 5 mortality by up to 30% for maternal mortality and up to 13% for under 5 mortality. And given the high unmet need for family planning during the postpartum period and the potential of preventing adverse maternal and child health outcomes through effective family planning, we thought that there is need to gain insight into the barriers and opportunities for postpartum long-acting reversible contraceptives within our catchment area. So we hope that our findings will help improve postpartum family planning services in the Mbale Regional Referral Hospital catchment area. So the general objective is to gain insight into the possible barriers and facilitators to delivery and uptake of postpartum family planning. And the specific objectives, we want to understand potential barriers to postpartum long-acting reversible contraception for women and their male partners. We want to gain insight into the perspectives of health workers on delivering postpartum long-acting reversible contraception. We want to gain insight into the perspectives of the community opinion leaders, such as the village health teams on postpartum long-acting reversible contraception. We also want to explore how postpartum long-acting reversible contraception services could be provided in our setting and how demand of these services could be maximized. So the methods is going to be cross-section study design with qualitative methods to collect data. And our study setting is going to be Mbale Hospital catchment area. This area has about 4 million people and 17 districts. The study population, we are going to look at postpartum women and their male partners. We want to look at potential providers of the postpartum long-acting reversible contraceptive services, mainly the midwives and the nurses who are able to provide these methods. And then we also want to involve the village health teams because they are strong opinion leaders in our community. The sample size, we are going to have a minimum of 4 focus group discussions, which will involve postpartum mothers, their male partners, and the village health teams. We shall also have key informant interviews with the healthcare providers who provide the services. So we shall include mothers who have delivered within the last 6 months. We shall also include health workers who are able to provide the long-acting reversible contraceptive services. And we are going to exclude mothers who had perinatal death, bad outcomes, and then those who had cesarean hysterectomies and those that will be critically ill at the time of our interviews. So the study procedure, potential clients and providers will be identified in their last antenatal visits and after childbirth while they are still within the postnatal ward. And we will purposively sample participants for key informant interviews and focus group discussions from the 2 broad categories of the potential providers and then the clients of for the postpartum long-acting reversible contraceptive services. We shall also seek participation of the village health teams. Data entry and analysis. The interviews will be audio recorded on a digital voice recorder, and the voice recordings will be carefully transcribed. These transcripts will be analyzed thematically using computer-aided qualitative analysis software such as NVivo or Atlas. And the interviews will be coded using a combination of deductive and inductive approaches in order to determine the major categories of barriers and opportunities for postpartum contraception. Yes. I would like to acknowledge Usitema University Faculty of Health Sciences, Mbale Regional Referral Hospital. And also this work is going to be funded by the early career grant from Royal Society of Tropical Medicine and Hygiene. Thank you very much for listening.
Thank you, Dr. Asen, for keeping time. Our next presenter is Dr. Lwasa Joel. He'll be presenting diagnostic accuracy of shock index as a screening tool for primary postpartum hemorrhage after cesarean section among women at Kawempe National Referral. Dr. Lwasa, you're welcome.
Thank you. Good afternoon, colleagues. So we carried out a study in Kawempe National Referral Hospital to determine the diagnostic accuracy of the shock index. To use it, to see how we can use it as a screening tool for primary PPH among women who have delivered by cesarean section. So we know that primary PPH is one of the leading causes of hemorrhage, leading cause of death among our patrons in Uganda. So that will be my outline. So shock index is the ratio of the heart rate to systolic blood pressure. We know that in non-pregnant people, the normal rate is between 0.5 and 0.7. While in the pregnant population, it can go from 0.52 to 0.89. Now, when you see a change or an increase in that shock index, as a health worker, you should be triggered to take action or do further assessment on the mother. In Uganda, we have been using the AMUS, the African Maternal Early Warning Signs, which has a heart rate, systolic blood pressure, respiratory rate, and levels of consciousness. Now, getting this assessment will take you about maybe 2 minutes to get a full score. And we think that this one will make it more cumbersome to use, and it will take more time. So we thought that maybe if we did a shock index, it will be a comparable replacement for the AMUS, saving time, but also requiring less resources. So our objectives were to determine the sensitivity, the specificity, the positive and negative predictive values of the shock index. We did a cross-sectional study in Kawempe, and we wanted to recruit 594 mothers who are over 18 years who delivered by cesarean section in Kawempe. We sampled consecutively because the program needed to end. So we wanted to generalize these findings to all women who deliver by cesarean section in Uganda, but we used the representative population of those women who delivered in Kawempe during the study time, and they delivered by cesarean section. So our study variables were the shock index, like we defined it, the systolic blood pressure, and pulse. So we are taking pulse over systolic blood pressure. And the gold standard in our study was the change in hematocrit. And to define PPH, we would say a decline of 10% or more from the pre-delivery hematocrit. And we are doing it at 24 hours, before delivery and at 24 hours. So we trained research assistants, we tested the protocol, we enrolled consecutively. Before delivery, we would draw a blood sample and run a complete blood count to determine the hematocrit. And at 24 hours, we also ran another complete blood count to determine another hematocrit. Then we would also take a systolic blood pressure and pulse rate at different intervals for every mother who has delivered by cesarean section who accepted to participate until we made 24 hours. So we analyzed our data. We summarized the continuous baseline characteristics as mean, standard deviation, and medians. We dichotomized the shock index and hematocrit change and used the 2x2 tables to represent those. We also used the receiver operative curve to determine the thresholds for the shock index. And we also used the starter version for statistical analysis. So that was the star diagram that showed the flow of our patient. So we found that the majority of our patients, of course, we took only participants about 18 and above, and majority were between 18 and 25. Majority were Catholics, and majority were married. So majority had achieved secondary education and were housewives. So this is a 2x2 table, but maybe to understand it is we got these results. So when we use the receiver operator curve, taking 2 hours as our study time, we determined a threshold of 0.8 to have the highest area under the curve. And when we took that threshold, we determined a sensitivity of 40% and a specificity of 82%. A positive predictive value was 3.8 and a negative predictive value was 98.8. When we did the same thing for 24 hours, we got the highest area under the curve to be represented by, to match the threshold of 0.7. So we took 0.7 as our threshold value for the shock index. It gave us a sensitivity of 70%, specificity of 54, a positive predictive value of 2.6 and negative predictive value of 99.1. So we realized that this 0.8 we have said gave us the greatest area, and that specificity, the specificity was quite high, but the sensitivity was low. Also, the negative predictive values. Sorry, and at 24, this is at 24 hours, 0.7 gave us the highest sensitivity of 70 and 54. While for the positive predictive values, we had 2.6 and 3.8. And this was because using our definition, we determined a low prevalence of primary PPH when we use the hematocrit change, which is quite different when people use visual estimation and other definitions for diagnosis. So And the negative predictive values were high because of the same. The prevalence of PPH was low in our study participants. So we concluded that the shock index is a poor screening tool for diagnosis of primary PPH after cesarean section. So we recommend that the shock index may not be included in routine care for postoperative mothers for early recognition of mothers at risk of primary PPH. And we also say that maybe we may want to fine-tune this study and see if we can fine-tune the thresholds so that you can get maybe a better assessment. So our gold standard could have been affected by fluid replacement. After cesarean section, we give mothers IV fluids. And also we had many mothers eliminated from the study because they received blood transfusion outside study procedures. Also, our shock index in our analysis, we took averages for each participant. So we took average at 2 hours and average at 24 hours, not a single time reading. So it may actually be a different story if you take single time reading. So we acknowledge research participants, research assistants, supervisors, statisticians, colleagues, and faculty members, and also Kawempe National Referral Hospital. Thank you.
Thank you, Dr. Lwasa Joel, for the confidence and accepting the limitations to your study. He deserves a big hand clap. You're all welcome. You're invited to, even before I complete, you're all welcome to ask questions. Dr. Susan was the first. I need an assistant. Yeah, first give her. Please address your questions to the presenter.
Thank you very much. Atwaire Susan, an obstetrician from Mulago Specialized Hospital. I'll just begin with Dr. Lwasa. I am actually proud that you've presented your results because sometimes people fear presenting negative results, but it's very good so that people would not waste time doing something that actually doesn't work. So thank you very much. Dr. Kayondo, in your presentation on pelvic organ prolapse, from your presentation, we realized that a quarter of your participants actually had infection. So I would want to know how that statistic compares with the similar studies. What could have been the possible reasons for that high infection rate? And most importantly, because you said infections affected the recurrence rate. So how can this be reduced so that we can improve the quality of life for these women? Dr. Kello, thank you for that presentation and the fact that DKT has a wide spectrum of attractive contraceptive products. Do you have the hormonal IUD? And if so, how much does it cost? Dr. Asen, just one question. Why would you exclude mothers with a bad outcome? Because sometimes they may get a bad outcome because of a pre-existing condition, and you may want to actually defer another pregnancy. Thank you.
Thank you very much. Dr. Lwasa, I like your studies. I think, and I like you, but I still, I like your courage that you have presented to us. You are men in your class, but you see, you are here, others are not. So, but I have one issue. You know, in those kind of studies, there are hypotheses, several of them which you could test. But you never made any of the hypotheses explicit. Probably that shock index equals severe PPH, what's outcome of PPH or something to connect. But I like the way you analyzed your work. The conclusion is why didn't you say why don't you say that it's still useful? Because something with a very high sensitivity is very good for screening. Specificity may be another issue, but at least for screening, that's why they use these HIV tests, and they use one with very high sensitivity, low specificity. And then they have other two tests, including a tiebreaker where necessary. But at least for screening, a test of that sensitivity is very good. Thank you.
Thank you, moderator, for giving me a chance. I have a comment and a question. And the comment is in relation to the presentation in your relating to fistula from Barara University. I've listened to all of you, and there seems to be a systematic equation where you are equating obstructed labor as obstetric fistula, and then any other fistula that you are meeting as iatrogenic. It happened in the morning. I've listened to you, all of you. But from the technical perspective, obstetric fistula as defined by the International Fistula Surgeons and the Technical Working Group in 2005 refers to all fistulas that result from the process of labor or its management, of which at that time, over 90% were due to obstructed labor. From the presentation by Rogers, Brenda, and so on, there seems to be that I hear when you do hysterectomy and so on, but if you go back to our traditional teaching, there is what we call obstetric fistula, and then there are other fistulas. And in Barara, from the presentation, I find you are having those caused by obstructed labor, you are calling them obstetric fistulas, and the cesarean section, the hysterectomies, the what, they are also obstetric fistulas, but not caused by the obstructed labor injury complex. I want you to, since we are teaching hospital. And then number two, you also seem to believe that iatrogenic fistula is increasing in that region. I was wondering, could it be a misclassification whereby when you have a reduction in cases resulting from prolonged obstructed labor, then you are unmasking those due to other causes? I want you to comment on that. And then finally to Brenda, you talk about thank you for the study you are planning to conduct. I think it is going to inform those who are interested. But epidemiologically, I fail to understand or qualitatively your design. Exactly what do you mean by qualitative cross-sectional study? How are you going to really implement this? Because traditionally qualitative study has a definition. Can you throw more light for the sake of this audience? And maybe Professor Danikaye, since you are talking, would you wish to really throw more light? Because when you were in school, qualitative designs they were different designs, but and quantitatives had different designs. But we seem to be having this issue of qualitative cross-sectional study. Exactly what is it? How do you design it? Thank you.
with my teacher, Dr. Nonge here, that, it's just a different lens, but you can have a qualitative study that is retrospective. You can have a qualitative study that's cross-sectional. But at this point in time, where the point in time may be a minute, an hour, a week, a month, 20 years, a century, that is the big section, like a big cake, and they are smaller cakes. Or you can have a prospective cross-sectional study. So I think there is no big issue about there. But the paradigm is that there are some people, some data research may be quantitative or qualitative. But currently, there also people believe that research can be mixed methods. But you have to give a reason why you are mixing, and you know how you are mixing the methods very well. I was going to say it, but I had some little books there. The producer hasn't brought them, but you qualify for a copy. That chapter is there. Chapter 6.
Thank you, Dr. Hayonda and team. I think the team from Mbarara is strongly biased to Eurogain, so I will go there. I think many of us in Kampala maybe will have lost our Eurogain skills, or never taught really. At the time I was training, I was told that vaginal hysterectomies are usually the preferred route for hysterectomy, because one is shorter stay in hospital, costs are lower, and recovery basically is faster with less infection. So is that a recommendation that the Eurogains still hold, or you prefer that we cut everything abdominally? Two, since I had the big, among the fistulas, you were saying repeat C-section appeared to be a very big risk factor when doing for hygienic fistula. So what exactly happens at repeat C-section? Is it a skill problem, or is it issues of adhesions and other things that may force the MO to likely then cause injury and fistula?
Dr. Waragaini, your first question, you didn't direct it to anyone. Okay.
Thank you so much. And I want to begin with a question put forward by Dr. Waragaini about classification of fistula. And the best that fistula due to obstetric fistula is any fistula which is both obstructed or any other process related to delivery. I beg to differ, because his references to ISOs. I've been a member of ISO. Yeah, he's been a member longer than me, and I've been there, but the most contentious organization in this world is ISOs. Even between ourselves, we fail to agree, disagree. At conferences, we leave when we are still disagreeing. According to 3 people in ISOs, they still clearly for them, and that's the references we use even as per World Health Organization. An obstetric fistula is a fistula which is resulting from prolonged obstructed labor with necrosis, ischemia, necrosis. That is typical obstetric. If a fistula is as a result of injury, probably during surgery, that becomes an iatrogenic fistula. If a fistula is as a result of cancer, then that's a cancer-related fistula. Or radiation. So that's a discussion which will not end here because it has failed to end at all forums of ISOs. Thank you. So next was Susan. Yeah, Susan, about infection. Infections were not, it was 10 in 10 patients out of 117, giving us about 10%. 10%. And so it wasn't very high, but it was significant because it led to recurrences. So it's still significant, even if it is 10%. And we think infections, vaginal cuff infections following vaginal hysterectomy occur when there's usually hematoma during the operation, get some reactionary hemorrhage, get hematoma, gets infected, and then the genital tract is a source of infection. So probably the best way to do that is to, we think if we couldn't control for it in this study, but probably because almost all patients got prophylactic antibiotics, so we couldn't control it for it. But if we did a study and probably give some, again, don't give the others, then probably we can think that if we give everyone antibiotics prophylactically, but that's not the only thing, because also the technique, the length of the operation, all those affect risk factors for infection. So there are so many things to control for, but probably we can take all those measures to reduce surgical postoperative vaginal cancer infection. Dr. Musana, it's not true that all hysterectomy, vaginal route is the preferred route for doing hysterectomy. That's not true. It depends on the indication, please. You not have a uterus which is 20-week size and you're going to struggle to remove it from the vagina. Definitely you'll fail, and it will now become even longer hospital stay, if not stay through the mortuary, because you'll bleed to death. So it just have to gauge the indication. If it's a cancer operation, you're an oncologist, I wouldn't start doing a hysterectomy for any cancer-related thing through the vagina. Definitely it's not the record, because you need to explore